Bwrdd and croeso and welcome to our board meeting. And we have a full agenda, so I'll be very grateful if questions and answers can be as succinct as possible. And if presenters can remember that we've all had the opportunity to read all of the board papers. If I go straight into the agenda, first item is apologies.
So thank you, Chair. We've got apologies from Donna Coleman, and Donna is being represented by Helen Williams today, Chair.
Welcome, Helen. Thank you. Next, declaration of interests. Thank you. Thank you, Anne. And Rodri?
Yeah, thank you. Just 4.2.1 Club Callum, just regarding that benefit.
Thanks, Rodri. And Judith?
Just to declare an interest, I'm the chair of the Regional Partnership Board, and there are items relating to that.
Thank you, Judith. We on to the minutes of the public meeting held on the 25th of May 2023. Is everybody happy to approve the minutes as a true record? Thank you. And then the minutes of the public meeting held on the 31st of May. Thank you. If we then go to the actions, the action log, please. So in relation to the 25th of May, are there any issues there? I have a number of questions on those in relation to dates. If I could pick up PM 2365, and that is in relation to a board seminar at which primary care is to be discussed and agreed. Do we have a date yet?
Thank you, Chair. We haven't got a date as yet because we've got a list of items for the board seminar which we need to meet with yourself and the Chief Executive to prioritise those. So we can update that for the next meeting once we've prioritised which will come to which seminar, Chair.
Okay, thanks. In relation to PM 2392, the Improving Patient Experience report, it is in relation to mental health and learning disabilities feedback and also the outpatients. Do we have a date for those to be considered?
We haven't got a specific date for either. I'm aiming to get it towards the October Quality Committee. But in the meantime, the learning disability issues I want to pick up through a quality panel in the meantime, which will probably be September, assuming that I can get the right people to that meeting. But aiming for October pending availability on the agenda.
Okay, thanks. If there's any slippage, if you could let the board know. Thank you. Sorry, if I could go back to 2391, it's in relation to the letter that the Chief Executive and I sent to Welsh Government on the 5th of June in relation to our land selection process for the new hospital. Have we had a response yet?
I haven't received a response. No.
Okay. I wonder if we could follow that up with a reminder.
Of course.
Thank you. Has anybody else got any matters on the action log? Phil?
Just on PM 2386, on the item around scheduling a discussion, whether the ethical framework should be developed, etc. We have, Chantal and myself and Helen Williams have had a discussion, but we now need to have a discussion with the Chief Exec, and we'll be scheduling that shortly.
Super. Many thanks. Okay, thank you very much. If we now go on to the next item on the agenda, which is my report. I'll take it that everybody has read my report. But I'd like to draw your attention just to some matters. We were all very deeply saddened by the tragic accident at Withybush Hospital. And as a board, we send and have sent our deepest condolences to Mabli Cariad Hall's family and everyone affected by her tragic death. And the board has and will and gives heartfelt thanks to all our staff who are absolutely incredible, and the parties, our partners who helped and cared with such compassion, dedication and expertise. And I know many of us here, board members, have been to thank people personally and to hear the great work that they did. As you can see from my report, there is such amazing work that's actually ongoing throughout the organisation. you know, a wide range from the 24/7 sanctuary for young people in Carmarthen, the outpatients physio service and the nursing school in Aberystwyth, the many awards, including the solar farm, supporting unpaid carers and veterans, and the finalists and the winners in the recent Royal College of Nursing Awards. I think often when we are facing challenge, we forget all the incredible work and the achievement that is ongoing. I'd just like to draw attention in the report to how wonderful it was to see our own Director of Primary, Community and Long-Term Care, Jill Patterson, quite rightly and deservedly receiving her Lifetime Achievement Award from her peers in the Royal College of Nursing. Well done, Jill, and well deserved. And it's with sadness I also say that this is our Director of Therapies and Health Sciences, Alison Shakeshaft, otherwise known as Ali to all of us. Her final board meeting, I think you've put your shifts in, you're going into retirement. Massive thank you, not only for what you've done here in Hywel Dda, but in your career in NHS and other organisations. You've made such a difference, so thanks, Alison. I promise I won't be nice to you. Okay, because you asked. Any questions on my report, please? Deli.
Diolch. I'd like to say bon voyage to Ali as well, who's sitting on my left. The question I've got, or the comment I've got really, is about the Welsh language provision for nurse education in Aberystwyth University. And in common with a few other board members, we have had walkarounds in Aberystwyth and Bronglais in particular. And what I can say is such a benefit and such a real plus for us in the region to actually attract Welsh-speaking local people to gain their nurse education. So I think we've got to be really proud of that fact, that it is going to help the patient experience within our patch as well.
Absolutely. And we're more likely to retain
people
from our own area. So thank you.
I just
Chantel?
wanted to add to that with my university hat on, is the fact that when all of the nursing programs have been recommissioned, that Welsh is a key requirement for us to meet in terms of transactional Welsh. And then obviously we will be looking at developing student nurses in terms of their proficiencies in the Welsh language.
Thanks, Chantel. Judith?
Yeah, it's a different area. It's top of page 6. As a carers champion, I would just like to call out Penny Muir, who received an award, and the amazing work she does to support carers, both those in the community, but also the system to provide support to our staff, many of whom are carers. And so also to note that Colin Hopcroft also was commended with an award. Thank you.
Thanks, Judith, and congratulations to everyone for the amazing work. Any other questions? Okay, thank you. The board happy to accept the recommendation in the report. If we can now go on to the report of the Chief Executive, please.
Yeah, thank you, Chair. I can be relatively brief. The report is probably brief for this month. That doesn't reflect actually though the amount of work going on within the health board at the moment. There's a huge amount going on, both to work on our delivery of our annual plan and recovery actions and the pressures within the system. But we'll come on to those in later papers. Just a couple of things I wanted to pull out. You've got the update there on the joint executive team, the JET meeting, and our targeted intervention meetings with Welsh Government. I think in summary, the focus was much more on the significant challenges that NHS Wales faces both now and into the future, and how they translate into West Wales. And it was positive to see the very many areas of positive feedback we had from Welsh Government on improvement and recovery that were in place. And I know that much of that, the detail of this will be discussed elsewhere in committees. Just to confirm as well, our status on the COVID-19 Module 4, where we've had confirmation that we won't be a core participant in that. But of course, that does mean we may get Rule 9 requests, which have to be dealt with quite quickly. And we're doing one in relation to a different module at the moment, which is a significant amount of work. There's been a long-running issue with the establishment. You'll see in other health improvement and wellbeing centre in Llanelli. I'm pleased to be able to give an update today. I think we should recognise there have been some concerns in the local community, and we're keen to continue to involve that local community in the development, and the planning application is in with Carmarthenshire Council. The further issues around our annual plan, we'll pick up at a later date, but much work going on, as I said, in the background to ensure that we pick up all the actions we agreed to get us back on track. And then finally, I wanted to also add my thanks to Ali. I'm going to try and make her embarrassed now. When I started in the health board coming from England, we didn't have directors of therapies and health sciences on the board. And I have to say, I was not convinced by the need for one. Ali has taken me on a bit of a road to Damascus about that, because I've seen the real value that you brought, both to the team and to the organisation. I think we are very blessed to have someone with your level of experience and knowledge about the subjects that you cover, but also, with a few exceptions, your relentless cheerfulness, despite the slings and arrows. So I know as a team, we are really going to miss both your wisdom and your happy demeanour. So, but we wish you well. I mean, it's lovely to be seeing you go off into retirement, and you should go with your head held very high for what you've achieved in this organisation, and as the chair said, for NHS Wales more generally. So thank you. I'm going to miss you.
I shall miss you all too, honestly.
Thank you.
Thanks, Steve. Are there any questions? Maynard.
Thank you, Chair. Steve, on the Regional Integration Fund Memorandum of Understanding, do we have any timescales from our county council partners yet for completion of their work? And what is not signed, are there any risks to the health board?
Yeah, I think good question. I will ask Jill to give a reflection. She may know more about this than me, but my understanding is that because we've recommended that they seek separate legal advice, actually the timescales will be dependent both on the level of advice they get and the type of advice they get back, which may need to pick up some issues on. In terms of the risk, I think this is very much a belt and braces. I think the working relationships and the way we've worked means actually any risks are largely theoretical, but this will ensure that we're really clear about expectations around behaviours, delivery, and so on. So I think it just helps to clarify roles, but I don't think we have significant risks in the meantime. But Jill, did you want to add anything?
Yeah, I mean, so I think, we've seen a maturing relationship, I think, over the years through our regional partnership board. And I think we have to build a level of confidence in terms of that. I don't think the issues are insurmountable in terms of the sort of finer detail that is going into this, but we want to make sure that we've got a governance arrangement that we know we're satisfied with, and all four organisations are satisfied with. And I think I know from my own experience, and haven't had that conversation with our current chair of ARAC, but I know that this is something that we continue to discuss through ARAC to make sure that we recognise the sort of finer detail of partnership, but also the individual accountability of the statutory organisations within that, because as we know, the RPB isn't a statutory organisation in its own right. And so the arrangement and the way in which we set it out legally needs to be clear for all of us, I think, in terms of that. But I think we're fairly near to the signing up of that. So thank you.
Thank you, Jill. Thank you, Steve.
If I could bring in the chair of the RPB, our vice chair, Judith.
Thank you. Yeah, yes, I don't repeat, obviously, anything Jill said. I do want to just clarify a point that's in the paragraph that's on page 2, which says that the Regional Partnership Board must match fund schemes. The Regional Partnership Board is not an entity, so it would be for partners to match fund scheme. That would either be the Health Board or local authority. So it doesn't have a role in this as an entity. I just think we need to be careful how we word these sorts of statements.
Thank you, Judith. And I think that's a trap that's often fallen into, isn't it?
Yes,
About this, yeah.
by external people, certainly.
Yeah, thank you.
Just on the MOU, Chair, this was a recommendation from Audit Committee, and the deadline we were working to was July. I think we agreed to, wasn't it, with the Audit Committee. There has been a slight delay. We have, as Jill's rightly said, the MOU is drafted. It's just with colleagues. So we're hoping by the September board, we'll be able to bring that back through our board and also through partners' relevant governance structures as well, Chair.
Thank you. If there is any unnecessary delay, then could you inform the Chief Executive and I that we may be able to help in progressing it?
Yes, Chair.
Okay, thank you. Okay, the board, Winston?
Hi, Steve. Thanks for your report. I just want to draw attention to the update on the can you hear me? On the year-end joint executive team meeting on the 19th of May. I noticed that Welsh Government really identifies 5 priorities. I was more concerned really about those things that we still need to do. There are no mention of mental health, which also has people waiting for treatment, and no mention of developing primary care, and no mention of the public health initiatives. Obviously we're going to need to do those things, but what are the implications of what they have clarified on our annual plan? Does that mean we need to go back and have a look at that, or what will we do?
In terms of the joint executive team meeting, actually that was a very full discussion of everything that we were doing. It's a backward-looking exercise, sort of like a performance review. So we did cover all of those issues in detail with them. Of course, we do have the ministerial priorities upon which our annual plan had to be based for this year. But you'll know, as a board, we signed off an annual plan which covered many more areas than that, albeit we do need to ensure that our capacity is focused on the things that the Minister has set up top priority. So it's a bit of a balancing act for us, but I think we have addressed that.
Thank you.
And Chair, just to add from a governance perspective, we have shared all the letters from Welsh Government in relation to both targeted intervention and JET through the Audit and Risk Assurance Committee, which the Chief Exec attends each meeting as well, Chair.
Okay, thank you, Chair. Jill?
It's only a very small point, and I hope it's okay to say this, but I just wanted to go to the UK COVID inquiry update, and there is a huge amount of work, and I just wanted to actually recognise the work of Joe and Sean-Marie and the team actually in helping us. We do require a lot of prompting, and I do understand that. There's a lot of detail to go through, but I think we appreciate having the governance team behind us actually in terms of doing this work.
Thanks, Jill. I think I'd like to reassure the public it's a really important inquiry, and our governance team, supported by an archivist, has kept every single document and timelines throughout COVID so that we're able to provide the information that's required, and as Jill said, help individual directors or board members with their statements. So Joe, can you pass that thank you on to the team, please, because it's really important that the records are retained, are accessible and are accurate. Thank you. So is the board happy to accept the recommendation? Thank you, Steve.
Thank you.
We now go on to ARAC, and that's Councillor Rodri Evans.
Thank you, Chair. Well, I take this read as well, but you can see the report that summarises the work of the Audit and Risk Assurance Committee on the meeting on the 11th of May. And the committee does critically review governance and assurance processes for a number of services business areas. Therefore, I'm not going to go through all of this. You can just kind of see what we have covered. We go through a lot of work and we scrutinise in detail. And I think just to say, during presentation of the accounts, the committee noted information relating to the IFRS 16, the new accounting standard effective from the 1st of April 22. And the IFRS 16 impacts on almost every part of the Health Board's accounts, with leases now required to be reflected as assets on the balance sheet. Therefore, just are you happy for me just to go through the consideration or approval of what's there? So if you can see, to endorse the ARAC annual report 22-23, the year-end processes, then the committee reviewed year-end documentation, including the NHS non-statutory instrument compliance report, Welsh Health Circular compliance reports, the draft ARAC annual report, draft head of internal audit, opinion and annual report, assurance report, and all that. And you can see we have looked at the one and the draft head of internal audit, opinion and annual report. Therefore, the committee received the draft head of internal audit report and was informed that the Health Board has achieved a reasonable assurance rating.
Thank you very much. Are there any questions? Chantel?
It's just a quick query around job planning, because we received limited assurance on this. And I think there's in terms of matters of concern, it's because of the fact that the delivery of actions lies with the operational staff. I was just wondering, well, what kind of measures are we taking in order to ensure that the job planning is delivered?
Could I add to that question as well? We had a board seminar last week and we realised the challenges that we face, and that there are some things that we have to pause going forward. And I wondered if this was in the equation, or it's so important that it has to be delivered and increase the assurance. Phil?
Yeah, so I think at the moment we should press ahead with job planning for a number of reasons. One of them is it's just such a key important such key importance for us to understand what our medical workforce is undertaking, and so it's critical for us to get an understanding around medical productivity, the link between pay. I actually think we should press ahead with this. There may come a point where it's difficult, but I think at the moment we should definitely press ahead. The other thing is there's considerable national interest in this across Wales, so all health boards are being asked to improve their job planning completeness rates and quality. In terms of how Andrew and I are working together, and Lisa, we do have a programme of work where we're splitting consultants into quarters, so they're very clear on when job plans should be undertaken. We've also got undertaken some training with the service delivery managers. So the training isn't just aimed at the doctors, it's also aimed at the managers. In fact, we spent some particular time with training the managers just recently. So there's a lot of work on this at the moment, and I do think we should press ahead, and I think I can see from exec colleagues nodding that they agree with that.
Thanks, Phil.
And I think, Chair, from an audit point of view, it was agreed that we will have a follow-up audit on this. Therefore, it is in the pipeline and something we are going to be looking at. Yeah.
Thanks, Rodri. Any other questions? I think we are going to approve the annual report later on in the agenda because it's actually tabled. But thank you for that. And thank you for agreeing to be the permanent chair of audit. Really, really appreciate that. So I think we have another audit report on the 20th of June next.
Yeah, thank you. Thank you for those kind words. I think I got big boots to fill on the phone, but yeah, I'll try my best. Therefore, if we just look at the papers again, I take it as read, but I think from what Joe said just now, the escalation status update, the chief executive does give updates on everything, and we are assured, we are briefed thoroughly on everything. And just on the second point, the review of the standing orders, as it is an attachment 2.6.1, I'll just read that the committee received a report detailing amendments to the standing orders and the standing financial instructions, noting the further Welsh Government amendments to the model as a result of disbanding of local community health council. Therefore, if we do look at the standing orders, which I have looked at, and if it's page 32.6.1, that is where it's it's changed, and you can see it's all been taken out. Therefore, yeah, so I'm gonna, as I said, take it as read. But I think if we do go on to the what's required for a board level consideration or approval, the revised standing orders and standing financial instructions, and also in regards to the execution of the contract for the construction of the day surgery unit, Prince Philip, the Health Board's decision to mitigate the breach of standing orders by proceeding with a JCT design and build contract dated 23rd of December 21 between the Health Board and Vanguard for the construction of the day surgery unit as a simple contract with a limitation period of 6 years from the date that the cause of action accrued. So those are the two specific points. Therefore, I don't know if you've got any questions.
Many thanks, thank you. Any questions, Chantal?
Just one in relation to single tender actions for service provision. I'm just wondering, how many patients are likely to be affected by the potential delays in bringing that on board? Which one?
Yeah, thank you, Chair. Quick question on the agency and rostering. It said in the meeting that we intend to remove all non-framework agency by the end of July, very near the end of July. And now I'm just wondering whether we're on target to achieve that.
Okay, I can pick up both those questions. One about the impact of the single tender on patients and the agency. Who's going to take the first one?
Chair, I can take the first one in terms of we would always balance any approval of a single tender waiver or rejection of a single tender waiver by balancing the needs of patients, so we wouldn't put patient need at jeopardy in that process.
And Chair, the second is with me, Maynard, in relation to the review. It is going to be challenging to finish it by July because the public inquiry has taken a significant more time of my time than as planned, but I am still working on it to get you something for the next ARAC. So it's with me.
Thank you.
Thank you. Any more questions? I have a couple of questions, if I may. The theatre loan trays and consumables. I just wanted to have confirmation. Have we changed our practice now in relation to cleaning and charging? And then my second question is in relation to the execution of the contract for the construction of day surgery. I wanted assurance that we've learned from that. They're my two questions.
Take the consumables on. My understanding is we've implemented most of the management response that we had. There were a couple of outstanding actions within the Scheduled Care Directorate around recording of those kits going in and out of our facility, but that was all in hand. If I can get an update outside, I'll give you a fuller update following the meeting if I can.
Thank you. And are we now charging when we use them,
Yeah,
or when we loan them?
As far as I understand, yes, it might tie in. My concern and why I'm not wanting to give you full assurance on that is because I think that there's still a bit of an issue with the Scheduled Care Directorate properly recording everything going in and out and when it goes and when it comes back to enable us to charge for everything. So we have started charging. Whether we're charging for everything is a question I would want to be more assured on myself.
Okay, thank you.
And Chair, on that one as well, because it was a limited assurance rating, it is going to be looked at again. Agreed to follow-up audit would be conducted within 6 months, and so it is going to be looked at. Kind of, it's very much on the radar from an audit point of view as well, because it's an important part.
Thank you. And the day surgery.
Do you want me to say that, Chair?
Thank you.
So to assure the board, there is an absolute process in place for applying the seal, which is in accordance with the standing orders. So we're really clear that that process is there. Unfortunately, on this occasion, due to I can't not fully explain why, but the process wasn't followed as we would normally do. So what we have asked internal audit to do as well is to do a review of how we apply the seal and check the process, just to make sure there's nothing that we're missing. So in terms of the process, that's absolutely fine. It's just unfortunate when the seal was applied this time, the process that there was circumvented. But it was with the best interest of getting the theatre ready, and we were working at absolute speed for that, Chair, but it's still not acceptable because we did breach standing orders. That's why there was a full discussion at Audit Committee and why the board need to be aware of that.
Okay, thanks, Jo. So the processes are probably very good.
Yeah.
And it's human error.
Yes.
Yeah, okay. Thank you. Any other questions? No, the board's happy to ratify the standing orders and standing financial instructions. Yeah, thank you. So the next item on the agenda is Quality, Safety and Experience Committee.
Thank you, Chair. So the report from our June meeting is as presented to the board. A couple of things to pull out, really. I guess the first is that there is a common theme running through our wide and varied set of agenda items that applies to most, if not all of them, and that comes back down to workforce capacity and the quality and safety issues that arise from an overstretched workforce dealing with more demand than it can cope with. And I think we need to be very straightforward in saying that publicly, and that continues to be an ongoing concern across many of the items that the committee is dealing with. I would also like to draw attention to the patient story and the issue around lack of communication with the patient and his family. I wonder if it's best to leave a more detailed conversation about communication to the patient experience report where it comes up there too. But I think I do want to step up the committee's scrutiny work around improvement efforts on communication. I think perhaps we don't really recognise just how significant this is for families when we get this wrong, and it continues to be amongst the top three themes, usually the top theme in the feedback that we receive. So despite there being lots of good stuff around communication, it is consistently an issue when we let patients and families down. So I do want the committee to step up its scrutiny around that. We picked up a couple of areas within our discussion last time where we felt, or we were asking questions really about the ambitious nature of some of the timescales for improvement. And I think in both instances, there's a sort of a going back around the loop to see whether those timescales are really realistic. But the committee's preference is clearly that we deal with the reality of what our services are facing than to be overly optimistic about when we can expect to see change. There is one issue to draw the board's attention to relating to the ongoing workforce pressures, vacancies around our specialist community of public health senior nurses. And that is particularly an issue in Ceredigion, linking to the health visiting service, an ongoing issue that we will continue to scrutinise through the committee. And finally, the terms of reference are here for the board, and I think they need approval. Yeah.
Many
Thank
thanks,
you. Happy
Hannah.
to take questions.
Any questions? Andy, you wanted to come in?
Yeah,
Deli.
sorry, if I may, just to reassure the board and the public, in terms of pressure damage, I just want to say, because this comes up repeatedly as an issue, we will be holding a deep dive through a quality panel into the pressure damage arrangements. I can assure you, however, that each site and each team hold monthly scrutiny meetings, and I see all of the audit reports that are undertaken through the tissue viability lead nurse. Some of the issues are down purely to coding, whether something is moisture damage versus pressure damage. And again, I do need to emphasise that these are not all inpatient pressure damage incidents of pressure damage. Some of these are where people have had no contact with any of our services and are coming in through our front door, and that's where we're identifying pressure damage. Doesn't mean to say it's right, it's wrong, but actually we need to think about, is there more that we can do to support public information, communication, to support self-care, to avoid pressure damage occurring in the first instance. So I just wanted to flag that and give some assurance.
Thanks, Mandy. And in relation to that, are we considering working with partners to help educate people how to care for their relatives or care for themselves?
Yeah, it's interesting actually. On a slightly different tact, I was talking to the week before, the senior nurse midwifery team meeting. We heard from the manual handling team who are actively working with social care to look at how they can support individuals in the home around reduced and alternative packages of care, particularly relating to manual handling, different pieces of equipment, etc. And in some respects, the opportunity, and it'll be something that Delith and I will have a conversation about in terms of charitable funds opportunity around certain pieces of equipment that I think will help and benefit, not just from a manual handling perspective, but also from a pressure damage, pressure management perspective in our clinical areas as well. So just from that one conversation, we've got some further work that we can be doing. Specifically in working with carers, it is something that I've asked the team to have a further review, and there's currently a piece of work going on with therapies colleagues to look at how we train and support carers around a whole wide range of self-care initiatives, from suctioning, positioning, all sorts of things. So I think we're beginning to get into that in more detail now.
Thanks, Mandy. Delith.
Thank you. Picking up on that point, I've got a further question, but picking up on that point, there is a wider issue in regard to nutrition and hydration. I'm working with our public health colleagues, so I know there will be a further discussion on that issue. My point is really on page 2 in regards to infection prevention and control, and I respect and recognise the demands on our clinical colleagues, but I am concerned that once again we are noting that there's only one episode of clinical engagement in the quality panels, and infection prevention is everybody's business. So I'd like assurance really on what steps or what mitigations there are in the engagement of our clinical colleagues.
Perhaps if I come in first and then Phil may want to add. So just to provide some assurance, Phil has actually written out to the through the Assistant Deputy Medical Director to all of our medical colleagues to encourage not just attendance at key meetings, but also around training around ANTT, aseptic non-touch technique, which has an impact upon infection prevention. And the one medic that is absolutely engaged, I can tell you, is a powerhouse in terms of engaging with her other clinical colleagues. So whilst there may only be one that came to a series of meetings, I know that she is engaging with the wider medical workforce. It would just be nice to have more direct input, which is something I know Phil is actively progressing. So Phil, I don't know whether you want to say anything.
Yeah, I mean, the one who does attend has a bit of a leadership role in it, so that I suppose is helpful. But I think do recognise though that, as Director of Nursing has said, we'd like to see some more of them around her. And that's why I've written out to the medical workforce about that. So I'd expect attendance to improve.
Thanks, Phil. Any more questions? Jill?
Thank you, Chair. I just wanted to raise a point or provide some assurance on page 3 around liberty protection safeguards update. The third sentence here states that the committee noted the number of referrals coming through the system and not manageable within the capacity of the team. And I think at the meeting, what we did provide assurance with is and it's probably just the wording of this, that there continues to be a backlog, but the process that we've put in place is indeed intended to make this manageable. So I'd want to provide assurance to the board that there is daily oversight of that backlog. There is a prioritisation of any escalation of any of those cases, and indeed in terms of enhancing our medical capacity, we have gone out now through national procurement to obtain additional medical capacity to support this process.
Thank you. One of the matters which is being brought to the board's attention is the concern about the ongoing unfilled specialist community public health senior nurse vacancies, especially in Ceredigion, and the potential impact on the safeguarding of children due to health visiting workforce challenges. I wonder if you could inform us what we're doing to try and address this, and Anna, will the committee keep this in its sights going forward?
Shall I come in? So yes, since the start of, well, we've made some changes structurally so that the team are now sitting within the wider Women Children Directorate, and already the level of input and support that they're getting has stepped up further. That doesn't mean to say it's going to change overnight. So they're already looking at role configuration, skill mix within the team. What I would say, however, and I do want to give an assurance, is that in terms of safeguarding, because they play a key role in safeguarding as much as the health visiting service, we don't have, as I sit here today, any significant concerns about impact of the challenges in terms of workforce that we've got around school nursing, feeding through in terms of safeguarding referrals. They are very active, and I would say that they do prioritise those children that are seen as at risk or potentially at risk. So from that perspective, they're working really hard. Trying to attract and retain and recruit into our school nursing workforce service is going to be something of a challenge. We are one of the few organisations that currently still only operates a school term service, and that is something that I know that the General Manager will be wanting to give some consideration to in terms of how do we make sure that we have full year coverage of our school nursing workforce, because obviously whilst children are outside of school, there is a lot of work still to be done and points of contact that can be made to support. That is something we're going to have to look at as well, but we will be taking back, and in fact on the next quality meeting in August we have a more detailed review of school nursing as well, so that will help us understand what further action we need to take.
Thanks, Mandy. Anna?
Yes, just to assure you, Chair, that this item has been on our agenda on a number of occasions over the last 12 months. We've been following it closely and we'll continue to do that.
Thank you. Thank you. Any other questions? Okay, the board happy to approve the terms of reference of the committee. Thank you for all the work that you're doing. Thank you.
Chair, sorry, just on the terms of reference, there was an amendment made at Quality and Safety, which has unfortunately not been picked up, and that was in terms of the Assistant Director of Therapy, so it's just a change to the job title. So it was, if we could approve it, just subject to that minor amendment, Chair.
Thank you. Board happy to do that? Thanks, Joe. Next item on the agenda is the update on the annual plan, and that's Lee.
Thank you, Chair. Yes, happy to take this. So the paper this time gives a very high-level overview of progress with the annual plan, but significantly focuses on the financial plan. So I'm only going to give a very brief update, and then I'll hand over to Hugh to take us through that aspect of it. So everyone knows the background to the annual plan, or board members are familiar with what we've done through board meetings previously. So the only aspects I really wanted to update the board on were the progress in monitoring our delivery of our planning objectives, which we take through our committees, and there's a link within the paper to those updates. So I won't go through those unless there are any specific questions. And then the update on the targeted intervention work with Welsh Government. So specifically what we're looking at from a planning perspective, to review and revise our approach to the planning cycle, if you like, taking into account the report that we've received now as part of that TI, which was a peer review of our planning approach. So that was a very helpful piece of work which we've now considered, and we discussed that as part of the recent TI meeting with Welsh Government as well. So we're in the process of compiling a complete response to that, which we'll take into the relevant committee as well, and track through that means, and obviously that will influence the development of our plan for next year as well. So that was all I was going to say, Chair, if that's okay. Now I'll hand over to Hugh on the financial position.
Thanks, Lee. Hugh.
Cadeirydd, diolch. I'll probably, much to relief, cover probably two papers in one here. So the paper 3.2 is the finance paper, and I don't propose to talk to that paper in much detail, only to say that I've somewhat changed the format of that to really make clear as part of a matrix where our deficit is falling across the organisation, and bring out a little bit more detail in terms of the forecast. That is the start of the shift in how I'll be reporting finances to the board, and that will continue over the next few months while we refine and adapt that. I'll speak more to paper 3.1, Chair, and the finance section on the paper explains a number of sections. Firstly, how did we get to the planned position? And I'm conscious that we've had a number of conversations as a board in terms of the makeup of the opening deficit to our plan of 112.9 million. Naturally, need to reflect that was at the time an unsupportable and unapprovable position per Welsh Government, and we reflected that in the deliberations we had in approving the plan. The second section is what's contributed to the deficit in addition to that 112.9 million opening position up to month 3. And there are a number of areas within that worth reflecting on. 3 million of that, so there's an 8.3 million variance at month 3 against the original plan. 3 million of that is a gap in identifying savings. A further 4.5 million is increasing pressures that weren't foreseen in the plan on our sites. That's made up of two main elements. The first being agency nursing, where we've seen an increase in fill rates quite consistently across all sites, but particularly in Glangwili. And secondly, medical agency, where we've seen the cost per shift increase quite significantly towards the latter end of last year and into Q1 of this year. The next area then is oncology, where we've seen a 500,000 variance. Doesn't sound significant, but it's a 3 million variance that we're forecasting for the year. Two drivers to that. We're seeing an increase in activity in our SACT units, and the cost of medication, cost of drugs has increased quite significantly there. Again, not foreseen as part of the plan, but there's a very stark increase in trend that we're seeing, about 15% year-on-year growth. And lastly, in facilities, also unforeseen maintenance activity going on within the maintenance team within facilities. So that's what's happened to month 3. In terms of the projection of what that looks like then for the full year, that's outlined on page 6 of the paper. We're seeing, assuming that green and amber savings deliver, which is not an unrealistic assumption, we're currently looking at a risk projection of 145.4 million against our opening plan of 112.9 million. That's a variance there, or a recovery that we need to make of 32.5 million at this stage. That's split between savings not delivering and the new cost pressures that we're seeing coming through. We have discussed as a board on the 31st of May when we met the items in table 5, we're on page 7, which are the choices that we have to drive some further improvements, and they are being pursued through the relevant executive leadership. And we've regrouped as an executive and developed the core delivery group, which is focused on financial recovery, and a communications cell that is focused on making sure that our communication to the organisation, to the public, and to stakeholders is clear. The meetings that we've held since the 14th of June, when we first convened as a core delivery group, are outlined on page 8, and you can see that largely the focus has been on agency and workforce issues more generally, and the actions that have been taken are included within that table. As a team, we regrouped with our senior management team across the organisation on 2 occasions now, the last of which was yesterday, where we have mobilised that team to address the challenge that we're facing, and the team as a whole is working to a 10th of August deadline to bring all of that back, to make sure that it's costed and understood, and that the implications of any actions taken are understood. I have a touch point meeting with Welsh Government tomorrow to take them through the latest update on our position. I'm sure that will naturally be a challenging discussion given the situation that we're finding ourselves in. And I have reflected within the latter end of this paper from page 9 onwards some of the strengthened responsibilities and approach that we are putting in place to reflect the situation that we're in, and to make sure that we're learning from the challenge that we find ourselves in, so that this isn't repeated in the future. So I think this is a strengthening position in terms of the reflections we've put in here, but recognise that the challenge we're facing is a very significant one and requires concerted action from everyone around this table, including the executive team and our senior team across the organisation as well.
Thank you, Hugh, and thank you, Lee. Open for questions. Anne.
Thank you. Was the uplift of 5% for the staff agenda for J Payne budget for this year pay award, or is it an overspend?
Sorry, I didn't hear you there. The pay award.
Was the uplift for the pay award budgeted for, or is it part of the overspend?
No, it's not part of the overspend, because that's paid. That's funded back to back by Welsh Government. So when that negotiation happens, it's the same every year with a pay award. We get a funding allocation as a result of it.
Thank you.
Thanks, Anne. Chantel.
Yes, I was just wondering around, I can see all of the plans and all the actions and the outcomes, but what I don't see is the actual impact. So you've got the core delivery group, which is it's a good initiative, but I just wondered around what impact does that have in terms of those measures that are being taken?
Chair, thank you. Much of this work is obviously quite dynamic and rapidly moving. So I've got an update in the appendix to it on the savings plans that have been assured to date. And we're working, as I say, to that deadline of the 10th of August to then finalise the latest iteration of actions that will come through to consideration at that stage. So we'll see the impact then.
Hugh, on the 11th of August, will we expect to see these ideas costed?
Yes.
At that board meeting then? Okay, thank you. Do you want to
I'll
come
come
in?
in at the
Okay,
end.
that's great. So, Andrew, did you want to come in on this point?
It was just on that
Please.
point, if I may, Chair. It was just to add, I think, in response to the question as well, is that the other key part of that piece of work over the next 2 weeks is to fully understand what impact any of the decisions or choices we have will have on service delivery, activity, performance, quality, safety, experience, all of the things that we would be worried about and want to have a considered view of in making any decisions. That's all part of that piece of work as well. It was just to give some clarity and assurance on that as well.
Thank you. I'm going to bring in Judith and Helen.
Thank you. I had a question about oncology, which was really, I suppose, to express some concern that so early in the financial year, we underestimated demand. So that makes me wonder how robust are our arrangements for predicting demand, because considering the emphasis on cancer and improving cancer weights, I would have expected us to be predicting that. And is something gone wrong in specifically related to that service or the information we had? So I'd like to understand that. May I ask another question, which is actually on the second paper, the finance report, because you said you were sort of taking them together. And it's on page 2. It's related to capital. And I understand what is there and why, but what that doesn't actually give me is the impact of having to spend extra capital in this area on the things that were in the programme that we are not now going to spend on. I'm particularly thinking about equipment. So if we cover those two things, thank you.
So, Andrew, do you want to take the cancer question?
Yeah, I can. I'm sure Hugh will have a view as well. So I think there's probably there's two sort of sides to this conversation. I think, I suppose my honest reflection would be, I think in terms of the demand and activity planning, we were very clear about what we needed to undertake this year. I think probably this was the challenge we discussed, I believe, when we reviewed the board, the plan the board had approved, and some of our reflections to you when we did that is the fact that there was probably a weakness in the triangulation of what we were planning to deliver in terms of activity and service terms to hit some of our trajectories and how that was translating into potential additional cost. I think there's also something in there around the additional cost isn't just about the activity being undertaken, but an inflation in the cost and the nature of the activity being undertaken in terms of drugs. So there's kind of a twofold hit on us in terms of oncology.
Hugh, would you like to add?
Yeah, I think Andrew's said it, but I wouldn't underestimate the impact being in a kind of high inflationary environment that we've got now. Any starting error, any starting issue with that lack of triangulation or lack of effectiveness in that triangulation has a big multiplier impact, and that's what we're seeing. Clearly, there's a very big inflationary pressure on medication, and that's having a real knock-on impact in any additional activity that we're seeing. So it's that double whammy is having a very real financial impact on us.
Thank you. And the second question was in relation to capital.
Chair, I might ask Lee.
Lee?
I'm happy to take that, Chair. Thank you. So, yes, it's a very important point, Judith. We've taken a detailed paper into exec team, capital subcommittee and SDOD setting out the position. We had a risk emerging where we were having to underwrite the costs of the firework, at least up until the point Welsh Government were in a position to confirm their support for that. We had always anticipated that they would, but clearly we couldn't leave ourselves in a position where we would risk overcommitting against our discretionary capital. So what we needed to do was pause some of the capital schemes temporarily to allow the Welsh Government processes to complete for that capital to come through in relation to the fire scheme. And then the second issue, as mentioned there, is in relation to the RAC, which of course is an unknown requirement at this stage. So we were needing to increase our contingency in order to respond to that. So both of those, we've set out what the implications of that are within the papers that I referred to, and risk assessed each of those. What I can give some reassurance to the board today, though, is that we had a very positive discussion with Welsh Government at our capital review meeting on Friday. They've indicated that they are going to support the fire scheme costs. We're working with them on exactly when we fix what those costs are, if you like. They're given us sufficient assurance that we can start to progress the schemes we temporarily paused. And on the RAC costs, that's obviously in a different position because, in fairness to Welsh Government, it's unknown for them as well, so they have to respond to that. But we had a very positive discussion, and the indication is that we will set out our best assessment of what those costs could be in year, and they've indicated that they would look to support us with that as much as that's possible. So we're going to work on that over the next month or two with them.
That's helpful and positive. Thank you.
Thanks. Helen.
It's just going back to the previous question and about measuring of the impacts, and we can't forget what impact it will have on patients. So if there could be a paragraph on simply what impact it will have on patients.
Yeah, thanks, Helen. Absolutely. And Rodri?
Yeah, thank you. Just back to table 4, and obviously there are those scenarios regarding the run rate forecast if it's green, amber savings, and I'm more intrigued and I think 7.1 is important, and the chair of SRCs here, and I agree with the sentiments there. The bi-monthly basis, I don't think that is perhaps sufficient regarding looking at progress and the savings. And I'm just thinking with Winston here, is it something that, I'm on the committee as well, but just from an SRC point of view, looking at the progress to these savings on a more regular basis might be an idea moving forward as well. But I don't know if Winston wants to come in as well. Sorry.
Winston?
Yes, I do. I agree completely, Rodri. I think with the scale of the emerging financial position, it's not long ago that we set a plan at 113 million deficit, and we're now talking of a deficit going up to potentially over 150 million. So I think it's really, really important that we keep an eye on it. But equally, I think I've agreed with Finance Director and the Chair that we will always have touch point meetings in between board meetings as well to keep an eye on it. And we need to strike the balance between over monitoring and also allowing execs and other parts of the organisation to actually do the job. So I'm very, very well aware of that. But the position is quite significant, and so thank you, Roger, for that. I was going to draw the board's attention to the table 1 summary of the core delivery group meetings, and that's on page 8 of the report. And a little concern I've got in that we do need to keep the pace going for the reason I already described. But medical agency and transforming urgent and emergency care, those are 2 factors which are huge emerging risks, which Finance Director Hughes set out on table 4. So medical agency cover, that's £4.3 million, and transforming emergency care, that's one of the key areas of overspending. So my question really is about have those meetings happened, and when are they going to happen? Because I think we need to really keep a focus as an organisation on that, but also keep the drumbeat about identifying savings or cost improvement opportunities, quantifying what they are, as well as recording what impact that's going to be on patients.
Thank you, Winston. Hugh, do you want to pick that up, or anybody else?
Chair, thank you. So on the 12th of July, so there are a couple of items on table 1 there where we said the meeting's not yet been held. Obviously, that was at a point of writing the report. On the 12th of July, I think it was, that we had the first mobilisation meeting of our senior team. And on the 26th of July, well, yesterday, we had a second meeting with our senior operational team. So naturally, those meetings meetings didn't happen of the core delivery group, but we did have that broad meeting of the senior leadership team, and we did supplement then in between the discussion on medical agency and flows. So we have had a conversation around those as a core delivery group. This isn't, of course, the only forum with which we have these discussions. So we have Directorate Improving Together meetings where we are having with each county, I think a couple of weeks ago, although the weeks blend into one, so I may be wrong there. We had each of the counties to discuss the impact of transforming urgent emergency care. Naturally, medical agency was picked up as part of that conversation, and use of nursing agency was also addressed. And I know that there are in between programme groups and meetings that are held. I'm afraid I don't have that detail. I'm sure Andrew will know about some of those. So there are other touchpoint meetings that aren't referenced necessarily in this report.
Thanks, Hugh. Okay, I'm going to bring in Anna.
Thanks, Chair. And 3 questions, if I may, relating to our operational teams and leaders. And I have said before that if we were judged on hard work alone, Hywel Dda would be at the top of every single league table going. But I do have some concern about our operational capacity around this plan. So our plan is predicated on the capacity and expertise of our operational leaders. And conventionally, we'd expect them both to run the services day to day and plan the services for the future. But when our operational system is running as hot as it is, and when the scale of our financial challenge is unprecedented to the scale that it now has become, is that dual role still realistic? Can we rely on that? The second question is around the accountability letter around budget delegation and accountability to budget managers. And I wholly support that being made really clear in writing, and I'm sure the recipients of those letters also wish to be clear with the board on that. Has the same occurred for their accountability around quality and safety issues, and how will that difficult balance between those 2 strands of accountability be overseen? And then thirdly, I'm mindful that during the pandemic, we were really celebrating the just do it mindset that empowered our leaders to get on and do what they needed to do without the traditional bureaucracy and clearance required through the organizational hierarchy. And we were really keen to hang on to that mentality and the spirit of that approach. Just wondering, with noting here the creation of some new meetings, some new centralized groups that will require the time of these managers, are we at risk of losing sight of the essence of what made management through the pandemic feasible? And is that just a moment to pause and reflect on that?
Could I add to those questions as well, in relation to the planning objectives and in relation to the incredible challenge operationally and financially that the Health Board and the whole of NHS Wales and NHS UK is facing at the moment? Have we had a conversation about perhaps pausing some of those planning objectives going forward to give us the space to prioritise and do what we think is the safest thing to do?
Shall I?
Yes, please.
So I start off on, there's probably a couple of things I wanted to say. Firstly, on oncology, just to add into the debate that we have had a discussion at an all Wales level around oncology, and I think everyone is experiencing the increase in volumes that we are experiencing. I think part of the forecasting challenge was, I think there was an assumption, and I think we made it locally, that this was a result of a pandemic surge, but actually it's continued. So we probably did, as NHS Wales, underestimate that, but it was unexpected that it would carry on this long. Just to add that, we have had that national discussion. So picking up Chantel's question around tracking of all of this, we have focused, I think, on rapid decision making to try and get ourselves back on track with a real acknowledgement that the faster we make decisions, the more benefit we'll have in year. But we do need to ensure that we're tracking all of that. So I have asked Hugh, through all of the decision making that CDG is undertaking, that we have a dashboard that allows us all to see, and we can share that informally with IMs, and that will obviously help with the discussions with the chair of SRC as well at the touchpoint meetings. And I do agree with Winston. I think the balance, we need to keep an eye on the balance between scrutiny, which is absolutely needed by IMs, but also allowing the exec team and the wider organisation to get on with recovery actions, which do need speed and focus. To pick up the other questions, particularly from Anna, I think Mandy might want to say something on the accountability around quality and safety, but in all the decisions that we're making, that is a key element of what we are considering and ensuring we understand the impact of decisions. Of course, most of the decisions in the context of this paper are around waste reduction, which has a link to improved quality, actually. So in some ways, that's less of a concern, but we do need to ensure that we are cognizant of it, given the amount of change that's going on. However, the bigger challenge, the 113 million that we've got, I think there will be some real discussions there about the nature of what we provide and where, and that will be for future board discussions. On the pressures on the team, and again, Andrew might want to say this, I would add it's also pressure on the corporate teams as well, who are also being asked to do a huge amount to support. It's a real team effort. We are operating at probably winter levels of demand and surge at the moment in the middle of July. So I think it is a real concern. However, having had 2 meetings with probably 50 or so of our senior leaders, the energy and desire to be part of this is really strong, despite the demands of the day job. And I think we'll only be able to deliver with their support and their knowledge, expertise, which sort of leads on to your other question around empowerment, and trying to ensure in addressing all of these issues, we are setting out what it is we need to do, but getting those teams with the corporate support wrapped around them to get on working out how to do it, and we try and keep out of their way on that. This does feel like the biggest financial challenge that NHS Wales is facing. Of course, that's the finances are just an expression of the wider pressures that the system feels, and the lack of infrastructure, the lack of staff, the need in our local populations. But I think my sense of us all working together on it, I think is creating that kind of pandemic style of response, albeit in a world which is much more complex, with many more things to consider than perhaps we had at the beginning of the pandemic. So hopefully that gives the board some reassurance, but this is really tough.
Thanks, Steve. And I think Andrew would like to come in.
Yeah, to be fair, Steve's probably covered a lot of what I would have added in terms of Anna's questions in particular. I think I suppose the only other thing I would say is obviously as part of the exercise, in particular in terms of the capacity and expertise, as Steve says, it's a pressure and demand across all of our teams in the organisation, whether they be operational or corporate, and how we all reprioritise activity to align to those things that are going to have the biggest impact for us now as we head through the rest of the year. I think what we're trying to do, and probably not surprising, but if we take urgent emergency care and the fact that that's one of the things that's driving our financial variance in year and the factors around that, naturally, the actions we're taking to try and improve the system, improve access, improve quality, improve experience, are all the things that will also help improve the financial trajectory as well. I think what we've tried to do, though, in the conversations over the last 2 weeks is really get the teams to develop a bit more of a laser focus on the 3 or 4 things that are going to have the biggest impact ahead of winter. I'm really conscious that when we get another 10 weeks down the line, we become very reactive to what's going on around us, and the opportunity to be proactive diminishes. So we're trying to really focus them on. So in the next 10 weeks, what are the 3 or 4 things we can get over the line that will put us in the best possible shape going into winter to meet the pressures and demands on the system, which, if we get that right, will also hopefully have a positive impact on all of the other things like the financial trajectory as well. That should also enable us to have a more sensible conversation with our corporate colleagues around how they can best align their teams and support around getting some of those things over the line. So we are trying to, we're trying to make sure that we're not trying to do 101 things. We're trying to really focus it on what's going to have the biggest impact, which is what we did in COVID. We had a lot of ideas, but we worked through them in order of what was going to have the biggest impact first. So that's the approach we're trying to take. As Steve says, I think the teams have engaged with that and bought into that. The challenge now is how over the next 9 weeks, as it will be by tomorrow, how we start to get some traction in terms of some of the change. The underlying information we've got and that we talked about through the Improving Together work in the last couple of weeks is pointing to the fact that the things we're doing are having an impact in the background. They're not just translating into some of those high level metrics at the moment, but we've got some confidence because we've seen on other sites where that's been the case, the metrics then start to shift a little bit further down the line. So I think with the approach we're taking is the right one, but certainly that capacity and question is one that we'll be continually reviewing with the teams, and has come through loud and clear in terms of the 2 sessions we've had around how we can help clear the decks.
Thanks, Andrew. And I think Hugh wants to come in.
Yeah, Chair, thank you. I've been reflecting a little on Judith's question earlier, and just the general position that we are in. I alluded to the fact that our original plan was unaffordable and unsupportable, which was the very clear message we received from Welsh Government. What that means is that there wasn't sufficient assurance around the cash, essentially, in order to support that plan. And therefore, whether the annual budget was perfect in its precision, while I'll always want to learn and refine and reflect on that, it's somewhat a moot point. There is a real issue here in terms of the cash affordability of the expenditure we're incurring every week, every day. On the back of that, the actions that we're taking now have to have 3 things, and I think Andrew alluded to this, but they need to be significant in value, they need to be variable in nature, and they need to relate to cash. And those are the 3 principles that we're having to adopt now in recovering the position.
Thanks, Hugh. And I think, Steve, you wanted to pick up the planning objective question.
Yeah, I think it probably rounded off a little bit. So in ensuring that we are focused on this, the exec team 2 weeks ago on the 19th did have a discussion around all of the other planning objectives that were in our annual plan. And I've asked execs to come back to me with a view about 2 things, really. One is whether by delaying them, we can free up that element of the corporate team capacity to further support the front line, but also those that may be being led corporately, but are having an impact on the time of our operational teams. And we can make decisions about whether we delay those in order that those operational teams are more free to either deal with this or indeed winter as it's coming. So we're doing that piece of work, and we will bring that back for a review at board.
Okay, thank you.
And Chair, just on that, it would also help with, if we do slow some of the planning objectives down, it will also change the committee work programmes as well. So that may help with some of the operational and corporate teams preparing papers for the committees as well. So it'd be the balance of the risk and actually what you'd see coming through committees. So it should all flow through then, Chair.
Similar to the pandemic,
Yeah,
really,
absolutely,
when we
Chair.
streamline governance. Okay, Maynard.
Thank you, Chair. It's a question really of something you just said about cash. I noticed in the table there's a big table of productivity gains. I'm just wondering how we translate the productivity gains into cash releasing gains that help our financial position.
Oh, I'd love to do that. We have probably for the first time put concerted effort into trying to understand the productivity gains that are being delivered across the system. And there are some very significant productivity gains being delivered. So patient-initiated follow-up, that has had a significant impact on outpatients, straight to test for cancer, another significant area that's had an impact. Translating those into cash is challenging, naturally, because that activity has been contributing to improvements in waiting times, not necessarily something that you would cash out at this stage. And whether you could at this stage would be a challenge. Some of the issues that we've had then, and this is a regular debate around value-based healthcare and the impact that's having. We're seeing some real areas where investment in community services has had a positive impact on reduced demand on secondary care services, but we're not seeing a reduction in the demand for beds because it's being overtaken by other challenges that we're seeing. So again, cashing that out is difficult because of those countervailing kind of factors that are contributing. But they were necessary things to have done in the first place, and the situation would be worse, would it not, had we not undertaken those. But I think there is a piece of work that we need to pick up around how do you assess that at scale and in an area, in a geography, to see whether you can realise the benefit coming out from it when you do bring all of those elements together. So that's I think an area of focus for us, probably for the next planning round.
Okay, thanks. Chair, one more comment, if I may. In the paper, it talks about laser focus of SRC on the finance. Whilst I support that in principle, SRC also supervises the digital work in the health board, and digital does provide opportunities, hopefully, for cash releasing. It's also got an ability to spend vast amount of money, I know.
Absolutely.
But I just don't want us in our focus on the finance side to ignore the digital side to our detriment.
Okay, thanks, Maynard.
Just really to pick up on the quality side of all of this, because we can be, whilst we are absolutely focused, laser focused, I would say, around the money, we are doing it through a lens of quality, safety, experience. And I think we have got the quality impact assessment tool that has been given to us through the Duty of Quality Act and some of the toolkits that have been made available for us to utilise. And that has been shared widely across operational teams. And also we've provided some corporate support to assist with the assessing of each and every scheme as they arise. I think it's important to re-emphasise the fact that there is still waste within our system, and that costs us money. It also impacts upon the quality and safety and experience of our patients, whether they're in a hospital or a community setting. So those are things that we are absolutely focused on through the quality impact assessments. And I think it's really important, because having done some of this work previously, when you do a quality impact assessment, you're actually looking for where not just the indicators might demonstrate a deterioration because you've had to take money out of a system, but actually very often you find that some of the indicators demonstrate an improvement because you've reshaped and redeveloped the way in which you're delivering services. So it's just important to keep that in mind, but we are absolutely looking at this through quality, safety, experience and outcomes.
Thanks, Maddie. I'm going to let two more people ask questions, and then we'll call this item or two items to a halt. Anna and Ewan.
Thanks, Chair. Thanks for letting me come back in. I just wanted to clarify what I was getting at in my questions. I am completely sold on the idea that better quality means better value for money, means lower cost. That is not an argument I dispute at all. What I'm trying to draw out is that when we sit and talk about that around a table and look at it on a piece of paper, that's a very different matter from being an operational manager at perhaps a Band 8 level, being right in the thick of it, having received that letter about budget delegation and thinking, right, what am I going to do about this decision right now when I've got 50 patients in A&E that I don't know where they're going, when I've got this letter about budget allocation and budget accountability? What is it that I'm going to do in the here and now? And I think it's that kind of minute day-to-day decision making that happens thousands of times over in this organisation in every 24-hour period where the risk lies. We won't lose track of the big things through our quality panels, through our other scrutiny. It's those minute things that happen day in and day out that can set off a domino effect very, very quickly. And it's that, I suppose, that our operational people are our eyes and ears for that. And when they are overwhelmed with other stuff, it's really difficult to keep a track of that. And there's plenty of evidence in the NHS of where that has gone hugely wrong. Yeah. So I suppose I'm just trying to say, can we keep this in mind, that there is only so much that any individual can do? And systemically, when everybody is in that position, we are running risks, and we shouldn't be too confident that those risks aren't lurking there ready to do some serious harm.
Yeah, a couple of things on that. I think that's spot on, Anna. And I think we must have concerns about a system that's under so much pressure as it is at the moment. And the reassurance around the big decisions we're making and making sure we understand the impacts of those is one thing. But you're right, day to day, people will be making decisions on the ground, whether that's based on their budget and accountability letter or just on what's facing them at the moment. I think it may be worth us just reflecting on maybe a communication out to the organisation just to reiterate the need to continue to focus on those things. And we also we use the harms dashboard, which is there to try and, sorry, the safety dashboard, there to try and highlight where we may be starting to see issues before they become significant issues, as a way of keeping a bit of a watchtower over that. So I think there are two things we can do in relation to that, but I think we should continue, as you say, to be absolutely vigilant and in our communications very clear to an organisation that is under huge pressure and got huge demands.
Thank you. I'm going to bring Mandy in on the same point, then I'll come to you, Ewan.
Yeah, it's just to emphasise that whilst staff at every level, and we do, and I know that there are conversations going on through the Medical Leadership Forum, the Heads of Nursing Midwifery Forum, through Andrew's operational meetings. So I meet certainly with the senior nurses, and we're really clear about the challenge, the ask. But in practice, on a day-to-day basis, the emphasis of needing to escalate when difficult decisions need to be made, when environments are under pressure, cannot be understated. And it's not unusual for either one of us, or certainly the general manager or the head of nursing, to actually go into a unit where they are experiencing significant pressures. And certainly at our front doors, we see and feel and hear that pressure every day. And I think you're right, Anna, it is important that people don't get scared and think the money is the priority, that actually it is about safety. And sometimes we have to take decisions, but we need to understand, have we taken the right decision at the right time for the right patient? And that doesn't always cost us more money, and it doesn't always mean that we've got to run higher risks. So I think keeping that in balance is really, really important. But being there to support our staff, that's what will help them get through this.
Thanks, Mandy. Ewan, last question.
Okay. I think I don't want to repeat what other colleagues have said, but I think what we perhaps I haven't heard quite articulated as clearly as perhaps I would have hoped to is the kind of looking at it with a different lens. Whilst we have to very much look internally to see where we can, realise the benefits, and the core delivery group, I think it's great that they're meeting to look at that and engaging with our operational kind of managers, as colleagues have said. But I think the lens I would also like to see reflected as part of that discussion is in our communities, because our communities will obviously be very aware of the pressures we're under as an organisation and the impact that that will have out in our communities, not just the patients who are in our care at any one point of time, but also those kind of wider members of the community who may be about to enter the kind of buildings to have the care with us, and they're going to be wondering, well, what does that now mean for them? So I think I agree that yes, communication is key, and the communication cell, as noted within the report, is going to be critical. But I also think perhaps, is it worth us also, as part of our discussions internally, also looking to kind of just reflect, how is this going to impact our communities and those community-based organisations, which I know he was already referred to in terms of the fact that some of our services are very much going into communities, which is, I think, a real positive step. But I think we need to perhaps think of the lens, as it were, from that community public perspective, in terms of how they can perhaps engage and support with us as part of the challenges we're facing, to make sure that it is a joined up approach. And what we're looking at not only benefits us internally in terms of realising some of the challenges we have, but it also can play in a positive way in and with our communities as well.
Thanks, Ewan.
Just on that, if I may, yeah, the communication cell is, as one of its 3 tiers, very much looking at how we can activate our communities to help us with some of this, because a lot will be doable at that level, which could really help the system. So that hyper-local comms plan is about being able to talk to individual communities about how they can help us. So we definitely see that as part of the solution.
Thank you. Well, thank you, everyone. That was a really important discussion, and that's why I've allowed such a length of time for us to scrutinise, seek assurance, and share our respective views. We have a recommendation there, but before we go to the recommendation, Helen, picking up your point, picking up Anna's point, picking up Mandy's point, and the whole board, the most important thing here is the care and the quality and safety for each and every patient who we have the honour to serve. We are not an organisation that will bang the drum just about finance. We are doing this in a measured way and a compassionate way and a caring way. and take on board the issue that you raised, Anna, about reinforcing that communication within the organisation. We've seen the impact of banging the drum just about finance to get foundational status, etc., elsewhere, and we certainly never ever want to go down that road. So I know that Steve and the exec will reflect on the best way to support staff and communicate the quality and safety and the care of patients first, and where they can go in these really difficult operational decisions that they may have to make day by day. And as Mandy set out, there are processes already in place, but maybe this is a time to reinforce them when we are under this financial pressure. And we also heard that the POs, there is a conversation, the planning objectives, and some of them may be paused in this period and may not, and that's a consideration, decision and recommendation from the executive team. Committee business will be streamlined as we did before, which will follow on if we do pause any of the POs. And picking up Maynard's point about finance and SRC and digital, it's every committee's business. And we had this discussion last week. Please refrain from bringing business cases and asking for more money at a time when we really need to get our house in order. There's a time for that later on. Winston, in relation to the SRC itself, thank you for agreeing to continue with the touch point. If you feel that more is needed than that, that door is always open. But as you quite rightly said, this is a time for getting on with the business and enabling the governance to be, as enabling as possible, to let people to get on with the job. So going on to the recommendations, and I'm going to go through them because this is a really important period in our year. So we note the assessment of the issues, and I think the assessment of the issues have been very clear, so thank you for that. Does the board note the weaknesses in our processes which have contributed to the challenges? Yes. They note the progress made by the core delivery group and comms cell. If I may say, it's actually a process rather than progress. There's discussion, there's ideas. We'll note the progress when it's quantified and it comes to the in-committee board on the 10th of August, if that's okay with the board. Note the savings plan, which have already been recognised. I think we look forward to the outcome of these discussions and our recovery plan. And we have discussed the quantum of financial risks. So is everybody happy to accept the recommendations subject to those small amendments?
Yes.
Okay, thank you very much for the collective nature of the working together in these difficult times and placing our patients and our communities at the heart of what we do. Is everyone okay if we go straight to 3.3? Or Hugh, do you want to? I know you've referred to your report at 3.2. I think we have discussed the current and crisis and where we're going rather than, yeah.
Absolutely.
Many thanks. So we agree with the recommendations in that report of 3.2. Is everybody happy with that? Many thanks. If we go into the integrated performance assurance report, over to you, Hugh.
Diolch, Cadeirydd. Just to pick up some, again, changes that have been made to this report so that the board are aware. I've appended now a presentation, which is an extraction from the dashboard that we have, the Power BI dashboard that we have on our performance, where those measures are relevant for the board's consideration and discussion today. Just some areas to highlight quite naturally, and a continuation of some of the discussions we've had at previous committees and boards. So planned care still doing well with the ministerial priorities ahead or near to trajectory at the end of the quarter. Number of breaches, breach measures reduced consistently since the end of March 23, which is pleasing to see. Within therapies, and probably worth just alluding to a deep dive that we had on the therapies position in the last meeting of the SDOD committee. Breaches are rising, particularly for audiology and dietetics, but there's been a sustained reduction in OT and an in-month reduction for physio, which is good to see. Within diagnostics, breaches have been reducing in line with the trajectory, particularly endoscopy and radiology, but cardiology and neurophysiology breaches have risen now for the last 3 months. Within cancer, naturally, the focus on reducing the backlog created by the pandemic. In reducing backlog, there's a deterioration in the performance measure itself, but I'm sure we'll end up with a discussion on where that's heading for future months. Patient experience is interesting because despite some of the challenges that we've already spoken to, overall patient experience is exceeding the 90% target, which is great to see and a reflection of hard work across our operational and clinical teams. Positive experiences noted in ED, Welsh communication, and being treated with dignity. But it is interesting, and I think there's a reflection here in terms of the impact that we're having through value-based healthcare. One of the key elements of that is that patients are involved in their decisions about their care. Only 76% of our patients feel as though they are involved in those decisions. Healthcare-acquired infections, I think Mandy would be shooting daggers at me if I didn't reference the improvements that we've seen in C. diff against the 20% target with the only health board to have achieved that. So I think congratulations deserved to the team for hard work in that space. Urgent emergency care, naturally still concerning given our position, our 4-hour position remains relatively static. So that's a worry. We've achieved and exceeded the trajectory for 1-hour handovers and seen a steady improvement in over 4 hours. But we're only slightly above the trajectory now for 12-hour breaches. And within mental health, improvements within CAMS measures, some exceeding the target, but neuro is still a concerning trend because the demand capacity imbalance we're seeing within ASD. So those are probably the areas that I'd want to pull out at this stage, and Chair, happy to open to discussion.
Many thanks, Hugh. Open for questions, discussion. Maynard, Mansell.
Thank you, Chair. Noticing the diagnostics on page 5, the successful recruitment to the trainee programme. It's really good news. And then 12 to 15 months gives us the ability to run more clinics. Just wondering whether in the shorter term, having the extra hands there will actually improve the situation before the 12 to 15 months.
Would like to take that?
Yeah, I'll take
Andrew?
that question if you want. Yeah, thank you for the question. Yeah, no, really pleasing to see the recruitment, because that's been, as we've talked about in several committees over the last couple of years, that's been a particular challenge in diagnostic services. I think it's worth noting that in terms of diagnostic capacity, we're already exceeding the level of diagnostic capacity in radiology that we had pre-pandemic. And so we've made really good progress in terms of re-establishing that core capacity. The extra pair of hands will help in the short term, but a significant challenge now is going to be more how we work across the region to look at diagnostics as in terms of the more routine cases waiting to find a more resilient solution. And that's certainly part of the conversation we've been having with Welsh Government and with Swansea through the ARCH programme as well, although it's at early stages. But yeah, no, really positive, and it was just an opportunity to point out that from a radiology perspective, we are now exceeding where we were pre-COVID in terms of the capacity delivery, although that's primarily focused on our urgent and cancer and emergency activity.
Thanks, Andrew. Mansell.
Oh, thank you, Chair. This is a clarity one, really. On page 4, when it says quicker diagnosis, point 3 on the third point, a new digital process for pathology has been introduced, where scanners are located at both Hywel Dda and Swansea Bay sites to instantly transfer images. Could you just explain that?
Yep, yes, the part of the digitisation process has been to make sure that images can be transferred from Hywel Dda to Swansea Bay. That's facilitating, in particular, the cancer pathway, and has made quite significant difference in the length of time it takes to undertake NDTs, and the very practical impact that it's having on the cancer pathway. there is a benefit being seen within pathology services, particularly in terms of their efficiency and productivity that we were alluding to earlier as well.
So it's pathology in relation to results?
Yes.
Right, okay, thanks. And second question, if I may, a lot of patients on the waiting list still, obviously, and we've talked about communication this morning. Can you just assure me that patients are being communicated with in relation to their long waits?
Well, I was going to say, I mean, Mandy might want to come in, but certainly the waiting list support project that we've had running to contact long waiting patients and maintain communication and give them a point of contact back and with us continues. I believe we've contacted everyone at stage 4 on the waiting list now. So they should, and they will all have a point of contact back into the organisation as well. I don't know whether you wanted to add anything.
I think one of the things I would add is that through the waiting list support, we've actually been able to expedite some appointments for individuals where their condition has perhaps not been stable whilst on the waiting list. And I think that's been a particular benefit of that service. And I think we're going to continue to try to ramp up and look at what more can we do to support patients, because we recognise it is a very worrying time for people just not knowing the date or what to do next to help themselves as well with care whilst they're waiting.
Mansell, if I could just add to that the waiting list service was set up as after a discussion with the CHC yourself about how when we stopped elective surgery because of COVID, to communicate with people. I think we may be the only health board in Wales to do this, even under the financial pressure that we've decided to keep so far that service, because it is so important that people aren't left and they're able to have that contact and that information. And as Mandy just said, if they are deteriorating while they're waiting, that we are aware of that. So thank you for that suggestion, which was a number of years ago now. Helen?
Can I just come in on one thing? It's
Helen.
great that you have got it. And
Helen.
It's great that you have it and people do have it. It's just some people don't know that you've got this service. And hopefully that we can work with your team, Llais can work with your team to say, well, yeah, actually there is a number out there that you can ring. So it's about communicating that number where people can ring.
Thanks, Helen.
I'll pick that up. And in fact, Alwena and I have been talking about the external facing website that we have for patients and our community. It isn't the easiest to navigate, I think it's fair to say. So helping people access the right number so that it is a single number that people are calling is certainly a priority for us.
Judith?
Yeah, thank you. I would just like to sort of note, and I suppose thank the teams involved with the improvement in the mental health side and the assessments for the 0 to 17-year-olds. That's a remarkable improvement, and I know there's been an awful lot of hard work gone into that. There is a but, and that is the area that Hugh pointed out and it's detailed in the main report about the other aspects of mental health, young people and actually adults around ADHD and ASD. And I don't want to create word, but at some stage, and this is maybe something we do in quality, I think we need to understand what we're going to achieve and what's realistic, because I think to keep measuring it against the measures that we have when we know we're not going to get there, it just feels as though we should have a different conversation about the expectations and about the processes and what might we be able to do, and also link that with what we're doing with partners around the NEST initiative, the NITH, and the No Wrong Door and one-stop shops and all of those things around that area.
Thanks, Judith. Andrew?
Yeah, no, if I could just say, no, I think I'd probably welcome the opportunity to have that conversation in more detail in terms of how we set a set of reasonable expectations for the service, particularly this year, in light of the significant challenge the service is facing and have articulated. I think the key piece of work I'm waiting for now is the National Delivery Unit review of the service, which they're undertaking across Wales, because this isn't a unique situation for Hywel Dda, but they've because we asked, they've started with us. So I think I don't want to be misleading, so I'll double check. I think it's September we're due to receive that report back, because we were the first organisation, as I say, that they were looking at. And I'm hoping that that will start to give us a better idea of how we can plan a more realistic response and agree a realistic improvement plan with Welsh Government as part of our enhanced monitoring arrangements as well, because it's certainly an area of focus in our monthly meetings with them.
Thanks. Thank you. Winston?
Yeah, yeah, my point was going to be about mental health, because there's some good, some bad. But on page 7 of Hugh's report, he reports that the percentage of mental health assessments undertaken within 28 days, age 18 plus, has been the lowest performance report since March 2020. And I noticed that there isn't a trajectory, so I think that's an area of concern. And it leads to my my earlier question about the Welsh Government priorities, but what I would say is that we need to have a trajectory towards improving this. Because we can't just, and I was also trying to triangulate it with the operational report later on in the agenda, and I just simply couldn't do that, because that looks backwards as opposed to forwards, and I think we need some more forward assurance as to how we're going to address that particular aspect of our performance.
Thanks, Winston.
Yeah, no, outside, that's fine.
Okay, thank you. Andrew, could you give us an overview of the cancer situation, please, and our projections for improvement and where we are in comparison with other health boards in Wales?
Yeah, of course. I was going to offer anyway to give a bit of an update in a couple of areas. So I'm happy to take the cancer question. So yeah, I mean, in terms of the single cancer pathway performance, 42% in May was the worst performance of any health board in Wales in terms of that position. I think and was obviously well below the trajectory we'd set ourselves. As we've discussed before, and I think as Hugh mentioned, as we're reducing and trying to reduce the backlog of cases that are waiting for cancer treatment and service, or diagnosis, should I say, because they might not all go into treatment or need treatment or be diagnosed with cancer even. So whilst we're dealing with that backlog in diagnosis, the very act of taking and managing and seeing the longest waiting patients on that backlog will impact on your single cancer pathway performance and push that down. Welsh Government understand that, they accept that conversation. They obviously are keen that we make as quick a progress as we can on reducing the backlog, so that our single cancer pathway performance can then start to improve, because that is the ultimate measure. But that explains the position for May. As we look to June, which we're still in the process of validating, I'm expecting the single cancer pathway performance to be higher than 42% and closer to 50. I don't know whether we'll quite get to 50. It depends on the last stages of the validation process that will go on the rest of this week and Monday. And it can only take a couple of cases to tip that in terms of the final number. But we'll also have made further significant progress in the reduction of our backlog as well in June, which starts to get us much closer to where we said our trajectory was going to be at this point for the backlog. And I'm expecting through July we'll have continued that progress as well from the feedback we've had from the service. So I think we'll continue to improve on both of those. There is a question I've posed, which is if our single cancer pathway performance has improved this month and in the next reporting month and our backlog's reduced, just need to understand the correlation of that, because that doesn't tie with what's happened before. And certainly the service have picked that up, and we're trying to understand that. It may just be because the number's getting down to a much lower level, so it's becoming more manageable. Yes, that's the cancer.
You also wanted to talk about some other areas. Take the opportunity.
I can pick a couple of others up then. I was also just going to highlight, so just to come back on the waiting list support service, we should also probably flag that the Minister has expressed an interest in coming to visit that service in the next couple of months, probably August, I think.
Yes,
I've had an email this week, so that will, and she wants to make an announcement from that visit. So I think there'll be some positive publicity around that as well, both locally and nationally. So that's always pleasing, because it's something that we've done well and they've replicated or wanting to replicate across Wales. I wanted to highlight in terms of a couple of things. So in terms of planned care recovery, we had some milestones at the end of June. We managed to achieve the trajectory we set ourselves for 52 weeks. So from referral to treatment, so that was positive. In terms of 104 weeks of referral to treatment, we were over our year-end trajectory, partially down to 3 specialties and areas. So as vasectomy patients and general surgery. We've had some challenges in terms of vascular patients and backlog in vascular because that's a regional service we commissioned with Swansea, and it's just been about trying to secure the capacity. I would add that one of the things that's happened in the last couple of months, though, that's really positive is that there's some really exciting work the podiatrists are doing in relation to the vascular backlog and triaging that and reviewing it. And they said they've asked the vascular surgeons to let them have a look at it and have a go a bit. And that sounds wrong, but in a positive way. They're trusted. I don't mean have a go, but what I mean was have a go at reviewing those referrals and see if they all needed to go into the vascular service. And it's worth saying that the vascular surgeons I know in Swansea very highly value the expertise and knowledge of our podiatrists and how they are and the support they give to their service. On that first 50 patients they've reviewed, they've identified 50%, 25 of them that could be seen by a podiatrist. So we might have another route into helping to resolve the vascular waiting times backlog, which has been a particular challenge for us because of that regional dynamic and just the capacity of those consultants. And the other area was trauma and orthopedics, where we weren't able to deliver the level of activity we'd hoped for the quarter. In my last update to the board, I indicated that we were awaiting confirmation from Welsh Government around the submission we'd made for planned care recovery monies. We've received correspondence on that now this week. I have to say that from a personal perspective, I'm disappointed in terms of the allocation we've been given. And whilst I understand the rationale and the approach Welsh Government have taken, I'm equally disappointed that that's had a potentially an impact on what we will receive as an allocation. So we will receive £6.6 million from that fund. They've made it very clear in allocating that money that they've not giving it out on a fair shares basis, or in terms of some of the plans that were there, they've issued it on the basis of where there is the biggest improvement needed in waiting lists across Wales. And so they're very clear they've allocated that disproportionately. So positively, the improvement we've made over the last year is one of the reasons why we've probably not received as much as we've received this year. But it's just to say we're now in the process of working through the £6.6 million allocation. There are some expectations around regional service provision with Swansea, particularly in, as I said, I noted earlier, around diagnostics and trauma and orthopedics as well, and how we work together to address some of the waiting times. But I think the other thing that we just need to assess in the context of that letter is they've also given us a number of delivery expectations this year that probably don't fit with what we said or align with what we said in our original submission could be delivered with the money we were asking for. And I would say would be extremely challenging with the allocation we've been given. I'm taking that, I'm obviously very mindful in raising that. I'm taking that in a very isolated space around planned care and the recovery. And as we get into a conversation around choices with Welsh Government around the wider financial position, there may be other discussions we have in that space. But in that specific issue, that's the process we're now just working through. But I thought I needed to highlight to the board that we'd now had confirmation this week of what we were going to receive. And then I suppose I can't not highlight that in terms of urgent emergency care, we've made good progress in terms of the trajectories we've had for 1 hour handover delays, which is positive. We still need to reflect on the fact the system remains very hot and very difficult. And only 2 or 3 weeks ago, we had another site in Gwilly had to escalate to a business continuity incident status because of the pressure it was under. They escalated very quickly. But, you know, to be in that position in June is unusual. It's also probably worth noting that across Wales this month, it seemed a lot more, the system has seemed much more pressured and highly escalated than it had done for the previous couple of months. So I think the whole of Wales is seeing an increase in pressure at least over the course of this period. The plans we've got around urgent emergency care, though, I remain optimistic will continue to drive the improvement we need to see in this area. The only other thing, and I don't know where you want me to pick it up, I could pick it up under the operational update. I think one of the things I'm also very mindful of and aware of is that with some of the issues we've got in an operational challenge, particularly around the RAC issue in Withybush and the potential impact that has on the wider health board system, that does present us some challenges looking ahead this year in terms of what that might do to some of our performance and capacity and the overall operational challenge we'll have across the system to manage that. So I'll flag that. I know there's a couple of points on the agenda where you may want to pick that up. It's in the operational update. I think it's in the Health and Safety Committee update as well. So I'm happy to pick that up more at the right point, but it's just in terms of the performance, it is likely to have an impact on performance as we go through the year. At the moment, we can't quantify that yet.
Yeah. Thanks, Andrew. I wonder if you could also cover delayed transfer of care in your summary. And could you tell us how much we did ask for in relation to the money compared to what we got? And with targets, we set our planned care targets, which were less than the government expected, but we achieved or surpassed. And do we intend to do the same this time? Set the targets which we believe are achievable.
Yes, on that, if I work backwards, I think in terms of that question, that's very much the review I've asked the team now to undertake with the allocation we've got, is to understand what we can now deliver and what that means for our trajectories. You'll recall from the original trajectories we submitted for the year that if we didn't receive any money, then we wouldn't be able to continue the improvement beyond June. So we'll have to revise those in the context of what we now believe we've got available to us. In our original submission, I think the total submission for us, which included some regional elements around endoscopy, diagnostics, orthopedics as well, was closer to 15 million, about 15.5 million, I think it was, that we put in. We've been allocated 6. I think had we got around 9 to 10 million, we would have been in a much stronger position in terms of what we could have achieved and delivered this year. So, and in terms of detox, the position's improved in terms of the overall number. It feels very variable though, because in month obviously there's a reported position that gives a census, if you like, on a given date. Through the course of the month, that does tend to change, and it can still get back to as high as 300, 305 we've seen in recent weeks in terms of overall detox in the system. As you'll see in the operational update, there is a breakdown of the reasons for that, and sort of the top 30-40% are around social worker allocation, social care assessment, and package of care commencement. There are then in terms of the volume, and the quantity, that's where most of those issues sit, and the work we're doing around trusted assessors and we've got the further faster paper later, is picking up on a number of those issues that I think will help address that challenge.
Thank you. Any questions? Helen?
Just go back on the councillor then, the ones waiting.
Your microphone.
I'm usually loud enough. Just going back on the cancer, I presume the ones waiting for treatment have had a dedicated nurse given to them so they can have contact and regular feedback from those nurses. And then my second question was about the tertiary providers. I presume they're doing in priority order, and what conversations are you having with with Swansea Bay or other tertiary services to bring the waiting lists down?
Yeah, so in terms of the question in relation to cancer, yes, they will have been allocated nurse. We also have a cancer helpline that's available, and every patient on our cancer pathway is issued details of that and that number, so they can phone that at any time, 24 hours a day, 7 days a week, to speak to somebody and seek advice or support around any aspect of their journey with us as they go through their pathway. And that is a very well used cancer helpline and something that we get really positive feedback around. So in terms of then treatment, yes, the focus is on treating in order of clinical priority. The specific issue that we're trying to pick up in terms of vascular, as well, in particular in terms of the longer waiting numbers, is there's a number of, because they come here to do clinics, and the number of clinics they do in accordance with the contract is small. Annual leave and bank holidays and issues like that can have a really negative impact on the available capacity over a period of time. So it's trying to work with our colleagues there to support them putting on additional capacity for us to make that activity back up. And that's a conversation that we're continuing to have with them. But the principle of treating in order of clinical priority and time weighted is one that we're all working to, and is something that Welsh Government are very closely monitoring as well in terms of treating turn rates, which is worth noting that from a health board perspective, we compare very, very favourably to the rest of Wales in terms of our own treating turn rates, and it's something Welsh Government often comment on.
Yeah, the Minister's commented to me on that as well. Judith?
Yeah, I just want to express real disappointment and concern about our allocation. It just feels, and I'll be blunt, like it's a rewarding for failure. And that I know there'll be a lot of issues around that, and I'm not naive to what those are, but I just think it's really, really disappointing. And I'm not sure I've got any ideas of what we do about it. I don't think we do anything, but I just think it's just a disappointment. And it was a very detailed paper which was shared with us all, and clearly showed what we have delivered and what we can deliver. And to have that and be actually told, well, if you hadn't done so well, you might have got more, it just defeats me. But I won't say any more. Thank you.
I'm going to bring Steve in at this point.
Yeah, I think we all share that disappointment. We can understand, as Andrew said, the reasons why they've taken the decisions they have. When you take a national view, the need to ensure that there's more equity across Wales with waiting times. However, it does feel like for organisations like ours who have perhaps been able to go further, faster than others on waiting list reduction, that's a difficult message for us to take in all of that. So I agree with the sentiment. I do think, probably I'm disappointed more on behalf of the teams in planned care who do remarkable work every day, that they may not be able to go as far as they'd hoped. And of course, they know these patients, so it becomes quite a personal issue. What we'll do, because the letter's only just come in, so there is an assessment, as Andrew said, about the impact. I think there's probably three things we need to understand before we decide to take which next steps, or three possible scenarios. One is that with this money we can continue to improve, but at a lower rate than we hoped to, and I think that's probably the best case. The second is that the money is sufficient for us to hold our position, which, as board will remember, the annual plan showed that it would be getting worse in the absence of any money. I think the one that would concern me the most is that even with this money, whether that will signal a deterioration in our position, so that the waiting times in Hywel Dda got worse. That would be something which I think we would need to consider further communication with Welsh Government about. But we need to understand that work first, and then probably take that offline and ratify it at the next board meeting if you have to.
Yeah, thank you. And we'll share the letter with all board members so you can see that, because it comes back to the impact on our patients and our people who are waiting in our community. And I think we could also consider, once we've analysed it, as you've set out, Steve, right into the planned care team, because they have been phenomenal in the achievement and the working together through bleak times and winter weathers, etc. They've really hit the targets that you set and surpassed. So we need to keep their morale up as well. But once we analyse that, and then if we decide to write, is everybody happy about that? We decide to write to the Minister with the detail of the impact on this. And I know the government is also facing very difficult financial choices, but it is a reward for failure almost, if you look at it as starkly as that. Any other questions?
Just to comment on that, I'm not sure what timescales the analysis will take. I'm just wondering whether there'll be any chance of an update for SDOD
Yeah.
at the end of August.
Good
I don't want
idea.
to put any pressure on people because I know, as we've already talked about, the pressure on people to
Yeah.
deliver is huge.
That's a good idea, Maynard. If it's ready, that would be the place it should go. Yeah, thank you. Okay, thanks everybody. The board happy. I know we're going on to the operational report, but you'll be pleased to know we're going to have a break first. So you have a 10-minute break and we'll reconvene at 22:12. So board happy to accept the recommendation. Diolch yn fawr, thank you.
One was just quickly in relation to the Gwilly Railway update and the scheme around car parking at Gwilly. In the report, we'd signalled that we were hoping that that work would have started by now and we would be due to open early August, that scheme. There was a delay, not our delay, but there was a delay with the contractors starting on site. We're expecting that now to complete late August and be ready for opening first week of September. So that will, whilst that's disappointing in terms of the delay, it will mean that we've got that additional those additional 150 spaces or so available, ready for the post-summer holiday period, when we always see an increase in demand on the car parking on the site. In the interim, we've also now opened 50 spaces opposite the emergency department in Bangwilly as well. So there is some additional parking on site already. So that will hopefully help ease the position as well as we get work through the summer. So I just wanted to do that because that was slightly different to what's in the paper, because that was an update I received after we'd written it. I think the other point I wanted just to pick up then was a issue that I referred to in the performance discussion, which was in relation to the RAC issue at Withybush Hospital. So just for clarity, RAC means it is short for reinforced autoclave aerated concrete, and it was a building technique used to develop kind of floor and ceiling planks in the 1960s and 1970s in construction. I know we've highlighted, I believe, that there was an increasing concern nationally around the use of this technique, in particular where there's been exposure to water and how that can make the planks constructed in that way more fragile and at risk of failing. We've been in a process, so it was always, because we were aware of the issue. It affects two areas really: Withybush Hospital and a small area at Bwrdd Hospital. The Bwrdd area of Bwrdd Hospital is above a plant room, so very low risk in terms of impact on service delivery and patient services. The areas at Withybush are slightly more widespread and include a number of ward areas on the top floor and a number of areas where we have the flat roof on the ground floor at the front of the hospital. So where we've got the outpatient department, the management offices, the SDEC, so same day emergency care facility, are all areas that we are aware we need to undertake survey work and inspection. That work has been progressing. As a result of that, we have currently had to close Ward 9 and Ward 12 in Withybush, and we've also, having commenced the survey work on Ward 7, we've also had to close 2 bays on Ward 7 on the back of the inspection work. What we're finding at the moment, so we've inspected thousands of planks, and it's a handful of planks in these areas that are being deemed high risk and requiring propping to secure them. Ward 9, we're at a more advanced stage of whereby we've identified the work, we've costed the work, and that work's commenced. So we're all due to have Ward 9 back in by the end of September for use. Ward 12, we're still working through the process of costing what that work will, what the cost of that work and correction work will be. But we don't have any funding for that yet, and we don't have a plan for when that will be completed. And obviously Ward 7's a step further back. Our concern as a health board has been and as an operational team has been, how do we make sure that we're appropriately managing the risk there? So one of the issues with this is until we get in and do the visual inspections of the planks, which requires going into pulling down the ceiling tiles, getting into the roof space and having a look at the planks, till we do that visual inspection work, the full risk is unknown to us. So we're having to, so until we've completed that, we needed to assess it. We've been looking at that and reviewing our process to that over the last couple of weeks, because the original plan was that we would do it area by area, do the inspection, do the corrective work, move on to the next area, because we felt that would have the most minimal impact on patient service delivery. Because of the high risk planks that we've identified in very localized areas, I need to stress they're in very localized areas, we have changed our approach to that and just spoken to Curtins for the surveyor and agreed a accelerated program, a 10-week program of visual inspection, so that by the end of that 10 weeks, we will have a very clear idea of the full risk that there is to those areas. In that space, we've obviously been working through our own risk assessment and seeking the relevant advice externally as to how we best manage that. And in doing that risk assessment, we're obviously having to balance off the risk, the potential risk around the ceilings and being those areas being in use by our staff and for users of service versus the clinical risks of if we were to shut all of those areas down, not provide any service, what harm and would there might be in terms of patient care and outcomes as well from not being able to deliver the services. We're still, we believe from our own work that in terms of the health and safety legislation, that the management plan we've got is appropriate in terms of the legislation as a means of managing that risk. We are just awaiting some, well, we had also sought though legal advice in terms of some of the issues around corporate manslaughter in particular, because that's a very significant issue for us. We've received that advice late last night and we're just now in the process of working through and considering that with a fine-tooth comb, line by line, what that means and how that changes or needs to change our operational response to this issue. I think whatever approach we take, there is obviously a very significant operational challenge in simultaneously managing the areas that are being inspected, vacating them to enable the inspections to happen because they're all in use at the moment. So as we're doing the inspections, we're having to decant patients or decant services out. And if there are issues, if there are areas that are deemed high risk at that time, they'll be propped. So that's a metal pole put up to help support the ceiling immediately. I guess the other angle to this that we just need to flag as well is that as well as the clinical areas, so in the wards, in the bays, in the outpatient department, these planks obviously in those areas also cover the corridors and walkways. So we've also got to be very mindful in doing the inspections. We may then have challenges in terms of if you have to put a prop up in the middle of a walkway, what that might mean for some of our fire and safety responsibility and issues like that. So it's a very live issue at the moment that we're trying to manage. There's a real logistical operational challenge around how we would manage that and how we will manage based on the lead-in time we've already had for Ward 9, which has been a couple of months, and the impact that might be if there are significant other areas of the site that we need to undertake similar work in. We're in regular discussion with Welsh Government, and I know Lee had a conversation on Friday with the capital team there around the potential capital requirements as we're seeing them at the moment, how they might be funded, and they've given us an ask around articulating back to them some of that a bit more formally. But it's just a very live issue, and in terms of some of the other issues we're talking about in terms of performance delivery and a number of the other things we worried about, it's obviously a very significant risk that we need to be aware of and are working through.
Thank you, Andrew. Lee, I wonder if you could give us an update on the Welsh Government response both in respects of the risk and the capital spend that may be needed to put this right, and in respect of accelerating our new hospital build?
Yeah, happy to cover that. So just, I suppose, point of clarity on in terms of what Andrew described. So there are 3, possibly 4 phases to the RAC work now. One is the visual inspection work that Andrew described, which is the quickest way we can take an assessment of potential risks. But obviously isn't as comprehensive as the full plank by plank inspection. So that's going to be the first 10 weeks. Then there's the plank by plank inspection that we've already done on Ward 9 and Ward 12 and in each of those areas. And then the third phase is the remedial works necessary to make those areas safe. In Ward 9 and 12, we've had single figure planks identified as very high risk, but quite large numbers that are categorised as high risk or red. And those are the areas we're going to have to respond to. The fourth potential phase that just in that is the removal of RAC entirely. So the remedial work we're describing, just so the board is clear, does not remove the RAC. It just secures it, if you like. And obviously, ultimately, the intention would be in the long term, we'd want to remove it, which is one of the objectives they've got in NHS England, if you've seen the communication around that. And I think that's where that becomes particularly relevant in terms of the strategy point that you mentioned, Chair. So to date, we have, through our own discretionary capital programme, committed circa 500,000 for the survey work, which is expecting to take between 6 to 9 months. Now, clearly, that will depend on what we find in each of the areas, and we've then further committed not far off 500,000 for the remedial work in Ward 9. So that gives you a sense of the scale of the cost of in each area of addressing this. We don't know, as Andrew says, the cost for Ward 12 yet, but we could surmise it's likely to be of that order. And depending on what we find in the other areas, clearly the costs are going to increase quite significantly, which relative to our discretionary capital programme is going to be very challenging for us without Welsh Government support, which is why we've sought that support. And as I mentioned earlier, in Friday's meeting, we've agreed with Welsh Government that we will give our best assessment at this stage of what those indicative costs would look like across the remainder of this financial year. And in Welsh Government, whilst not in a position yet to confirm support of that, have responded positively to that. They recognise that there's a need to work with us on that, albeit recognising that none of us know the costs yet. So there is a challenge in terms of the advice that they can provide to Minister on that. So I think my objective in that regard is that firstly we avoid the impact on the rest of the discretionary capital programme as much as possible, as per Judith's question earlier. But secondly, that we don't allow the costs of the remedial work to significantly delay the remedial works, because as Andrew said, that has a direct impact on the ability for us to deliver services. So we've not faced that yet because we were able to deal with that through our discretionary capital. But clearly, if the costs escalate, then we would be in a situation where we'd be dependent on Welsh Government, which is why we're trying to get ahead of that really in those discussions. So that's where we are at this point in relation to that. I think in the context of the strategy work, I think it further emphasises the need for us to address the challenges and limitations we've got within our existing estate. Withybush is an obvious difficulty there, but equally Glangwili has got many challenges as well, and the RAC will potentially be a significant sum of money. I don't know what that might be yet, but you could see it could be low millions or a number of millions. We've also got then the fire works that we're obviously doing, the work to address the fire risks, and then the business continuity work, which is into the tens of millions across those sites. So So part of the discussion we're having with Welsh Government, and part of the rationale, I suppose, for our programme business case and our desire to progress that as quickly as possible, is that what we don't want to do as an NHS Wales, not just the health board, is commit money now purely to keep buildings going that we don't see a long-term future for because of these issues. That wouldn't be a very good use of public money in my opinion, our opinion. So trying to get that progressed as quickly as possible so that we avoid incurring double costs, if you like. Now, that probably, given the timescales and the speed at which we have to respond to RAC, that probably is less relevant for the RAC specifically, at least in terms of the remedial work, but it is relevant when it comes to the removal of RAC. And it certainly is relevant when we come to look at the business continuity costs that I was referencing earlier as well. So I hope that covers the points, Chair, and happy to take any questions.
Just could you cover whether the Welsh Government is aware of the risk?
So we've been very explicit about the risks, and they've had reports in relation to that, and we've been sharing our papers with the capital team. I think now that we've had some further legal advice on it, I think that's one of the points for us to consider, is how we then articulate that clearly to the Minister and Director General and that.
Okay, and for the board, I suggest we discuss the legal advice in committee today, so that the board is aware of it, or it's legal professional privilege. We shouldn't be discussing it in open board. Thank you. Any questions on the whole of the ops report and the RAC issue? Judith?
Thank you. Just to confirm, the Health and Safety Committee, which I chair, is monitoring this position. And I should point out in relation to RAC that we're just talking about Withybush, and Andrew has also covered the situation at an area in Brondlais. We've yet to survey any community facilities, any clinic facilities. And the team is also taking advice in relation to the position with GP premises, which obviously we don't own other than those that are managed practices. So we will keep a watchful brief on all of that. I should say, in relation to the Health and Safety Executive, they have indicated this week that they won't be having a national strategy in relation to this, and they are content with our plan. So that is one thing that we won't need to face. The positive thing I was going to say, if I could, is actually refer to 111, press 2, which is referenced on page 7 of the report. And what that doesn't say is that we were the first health board to introduce 111 press 2. We were the first health board to go 24/7 with this, and to introduce the professional line for GPs, ambulance, other police, etc., to be able to link in with that number. And I do know that the team apply, because they're now getting information on the nature of calls and what's that, because I know that conversation has got to be had. And if I may, just to link that to report to, is referenced in the CAMS service in the same report, because it's also available for children. And I've lost the page as to where that is because the admin control closed down, but it's also referenced later in the same report. So I did want to thank the teams for their introduction of that and really leading the way. And it's been visited by the Deputy Minister, who was very pleased to see the service. Thank you.
Thanks, Judith. Phil and Jill.
Yep, sorry, to go just back to RAC for a second, and with reference to Andrew's point about the fact we've lost some capacity, bed capacity, given the fact that we've lost some capacity and we've got really significant pressures on the system, it is impressive the work the team's done on maximising the use of our community services and community capacity to mitigate the impact of that. And Withybush still performing well. So our teams, I think, have done a really sterling job in mitigating that. But of course, if we were to look at other loss of capacity and a significant scale, there is a limit in the moment to how much mitigation that those teams can put in place. So I suppose that's part of the concern, really. They've coped with it so far, but much further would be quite a challenge.
Okay, thanks, Phil. Jill.
Thank you. And I guess that was really my starting point to actually commend the teams in terms of the work to clear thy ward in South Pembs. And I think it's been an opportunity, I guess, to also look at our longer term strategy in terms of the delivery of that service. But it has required staff to work differently and to work in a different environment, and also for patients. But I think it's very much using the opportunity we've got to help us deliver that work in a more timely way, albeit I think I take Phil's point that not all patients in all of those wards will be able to be suitable for stepping down into a community facility. There'll be a lot of patients that still require an acute setting. So that was one of my points. Just in terms of some of the other points in terms of integrated localities, I just wanted to draw board members' attention to the commitment that we are progressing around Nayland and Johnston as we had agreed with the board. So we're starting the work now to firm up now what that procurement opportunity will look like around going out to test the market in terms of that, and we hope that we will be able to award either a GMS or an APMS contract at a later point in the year for the Nayland and Johnston population. And then I think for a large part of the report we've set out, I really want to draw the public's attention as well to the issues around access. And we've set out the access standards. I think people still are possibly confused around what is on offer. And I think patients do need to be aware that it is a standard now that's mandated through the contract, but not all appointments should be released at 8 o'clock. There should be a range of appointments offered within every practice that is working to that standard, and all of our practices are at phase 2. And indeed, the attempt should be to try to manage an individual's request within one phone call, not saying all the appointments are filled, can you ring back? So there should be an opportunity as well within practices to forward book appointments as well. So we are looking at that through our access reviews. As you know, we have to have an access committee within the health board, and we monitor that on a quarterly basis, and we do pick up very seriously where we understand that practices are failing to reach their access commitment in a reasonable way, and we've done some very detailed work with some of our practices around managing that for our patients. So we have included that in the report today.
Thank you, Jill. Winston?
Yeah, thank you, Chair. I just want to refer to the transforming urgent and emergency care in the operational report. I think it's on page 3 of 16. And it describes the setting up of 2 key work streams to drive improvement. Could the director just confirm what areas of improvement we're expecting to come out of these 2 groups, and what kind of key outcomes we're looking to track as a board? Because I've read it a couple of times and I wasn't quite clear what those were.
Okay, thanks, Winston. Andrew?
Yeah, I can pick that up. I think there'll be some detail to this covered, I think, actually, in the paper we've got on Further Faster and the slide set, which talks around a number of the metrics we're tracking across the programme. The 2 groups, though, the Integrated Home First group is really around, well, again, I'm in danger of repeating what I might say later, but in many ways, what the Integrated Home First group is, and the Home First approach that's trying to oversee across the region is the operationalisation and response to the Further Faster policy documents. That's around how we increase capacity in the community and across health and social care to meet the needs of our population and support keeping more patients at home and avoiding them having to come to hospital in the first place, but also when they do get to hospital, discharging them and getting them back to their place of residence as quickly as possible, and with appropriate care needs. So that's what that first group is looking at. The second group is around the management of conversion and complexity, and this is very much around the fact that we know that, as we've talked about before, that patients that stay in our beds, we know that when patients get to 21 days length of stay, and they often stay a lot longer than that. And this is around trying to significantly reduce our length of stay in hospital. and with a real focus on our cohort patients that would be considered frail. The first kind of the sort of 2 high-level metrics that we've really been asking that group to focus on is because we had some very long waiting patients, some over 200 days, some over 100 days. It was a real focus on how do we significantly reduce the number of patients that were waiting, that were in hospital for those excessively long periods of time. And we have made some really good progress already on that. I think we've reduced the 100 days by almost 50%. So that there is some really good progress there, but that's very much around how we reduce length of stay, both in terms of management and of patients when they're in inpatient wards and in beds, but also in terms of how we can turn more around at the front door and within the first 72 hours. Because again, we know that's a time critical period for being able to avoid those longer lengths of stay at a later date and reduce need. I think the other thing with this is it's also around reducing need for social care, which obviously supports the discharge arrangements too.
Thank you. Thank you.
Chantal?
Just in relation to that, I'm just wondering, do we have a policy within the board around admit discharge? Because I know on my walkabouts, when I've asked around length of stay, they're around 100 days to 200 days of the wards that I have visited. But when I asked this question around admit to discharge, there was people were a little bit vague around that, and so I was just wondering whether we do have that policy in place.
That might be a question to raise in the further fast run.
Yeah, we can do. I think, the principle of estimated dates of discharge, if you like, at the point of admission is one that's obviously been something from an NHS perspective that's been a principle of good discharge planning for a long time. I think what we found, particularly over recent years, is engagement with that has become more difficult as some of the discharge processes become more challenging. So because of some of the capacity challenges we've had out in the community, there was a sense that it almost didn't matter what estimated date of discharge was set at the point of admission, because it would always be overridden at some point by all of those other factors that from a ward perspective were potentially external to what they were doing. Not entirely, because I think we would all recognise that there are things from a health perspective we can do better in that space. One of the, and I'm sure we can talk about this in a moment because Rhian's at the back, and when we do further faster, she can join us. But I think the one of the exciting pieces of work we've been doing with Hugh and the digital team is around how we use digital technology and artificial intelligence to help us do some of that predictive work. So it's almost generated at the point of the patient being assessed by the nurse and triage, so that we get that generated automatically, and that gives us a target to be working for that because of the nature of AI takes into account a number of those variables that at the moment the ward staff might say are challenging for them to kind of form a concrete assessment.
Phil?
Yeah, one of the things I was going to say is that in our strategy, just relating what I said earlier about the teams in Pembrokeshire and your point, all and this area of this paper are all part of the assumptions that we derived in when we developed the clinical strategy, the Healthier Mid and West Wales strategy. All of those assumptions are built on this kind of work, which is why we're putting so much effort into it in the lead up to the new hospital build, because a lot of this needs to be in place by then. And indeed, of course, we've got the Nuffield Trust reviewing our clinical strategy at the moment and assessing our assumptions against this kind of work.
Thank you. The board's happy to accept the recommendation of the report. Thank you. May I apologise to our colleagues who are at the back for the delay and welcome you all. That's Eldeg, Catherine and Rhian and Louise. Oh, it's Louise, I didn't recognise you, sorry. got your glasses on. Welcome. We've spent a lot of time this morning, as you would expect, looking at patient safety, our financial challenge, and performance, and it needed to be done. So we are running a bit late. So you're very welcome to sit at the board table if you wish, or you're very welcome to stay where you are. It's entirely up to you. And I'll try and put your bits together so that you don't have to. I know, Eldeg, you've got a couple of reports in there, so you don't have to have a space in between. So we now go on to the clinical services plan update, and that's Lee, 3.5.
Thank you, Chair. I'll be brief by way of introduction because obviously we are behind on time. So this is an update on previous papers. I'll just draw the key points for board members to be aware of. Firstly, we've now got a better fix on the timelines, at least up to the point of the issues paper. So we're now intending that the issues paper to incorporate all the services we're describing will come to the January board. So that's slightly later than we'd intended, but is as a result of that more detailed project planning. We have done a detailed assessment of the resources required for this, because board members will appreciate it's a significant programme of work covering a number of areas. So we have undertaken that and got to a position on that, and that's not just the project resource, but it's also the operational teams, the workforce, and digital, and so on. And that is something that is going to feature in the AO letter, the accountable officer letter, going to the Director General shortly. And in the meantime, we're looking to reprioritise work, recognising that we don't have the resource at the moment to recruit more people to support that. So that is a challenge for us. Then there is an update on each of the service areas, so board members to be aware of. The most significant of those are the urgent emergency paediatrics work. We've just gone past the midpoint review of the consultation, which is well underway, and we've added some more public dates to that. And then there's a significant update on the stroke work. So there are two things to note there. Firstly, that a business case has been developed regionally with Swansea Bay in relation to the potential development of a comprehensive regional stroke centre. And then associated with that, we've undertaken a rapid assessment of the resources required in Carmarthenshire in the first instance to look to meet stroke standards and support the stroke pathway if indeed that comprehensive regional stroke centre was developed in Morriston. So we've taken both those papers to SDOD committee for a discussion, and of course we discussed it as an executive team as well. So the only other point to note on the stroke aspect of it is that we have had some positive news in relation to securing additional funding, which we can put towards the enhanced discharge service. So over 640,000 for that, which is going to support stroke services across the 3 counties. And then the only other point to draw to your attention is previously we've talked about outpatients as a distinct piece of work. We've now decided to incorporate that into the relevant services. So that means we'll be doing an outpatient piece of work in the services mentioned, but not comprehensively across all areas, because that was the most appropriate response we felt through the steering group discussion. And finally, endoscopy is now going to be incorporated within the diagnostics work, so we align with the regional and national working. So they're minor points, but just to draw that to people's attention as updates from the paper.
Thanks, Lee.
Thank you.
Thank you. Any comments or questions?
Please.
Helen.
Thanks.
Helen, your microphone.
Thank you. So, emergency general surgery, I can see you've employed 2 surgeons, even though they're locum, so I presume that will go back to normal service now instead of being interim closure at weekends or nights.
So I can respond to that. Unfortunately, the answer is not quite as simple as that in terms of those locums. It will certainly provide a lot more resilience to the cover on the site during the week and during daytime hours. It's not thought, the last update I had from the hospital director and from the scheduled care clinical director was it wasn't thought that the individuals appointed would mean that we could restart the on-call rota, because they're not necessarily going to be on the on-call rota out of hours, but it will help, because they're locums, that is, it will help though shore up the daytime on-call rota that's currently being serviced only by a couple of the consultants on site. So that's still a conversation and discussion in terms of the service model and how we would re-establish the emergency general surgery on call within the context of this work, within the context of the service and the clinical leads.
Another reason for a new hospital. Okay, thanks, Helen. Mansell?
Yeah, thanks, Chair. Back in February, the Stroke Association wrote to every stroke patient in Hywel Dda, outlining their concern in relation to Carmarthenshire County Council pulling out their funding from the rehabilitation service. Can I just ask Lee, does that extra money now mitigate that, or whether?
Yeah, bring in Alison to answer.
Alison.
Okay, Alison.
Yeah. Can I do a bit of a wider, just a bit of a
Do you wanna-
wider update
you
about
put
the
the
stroke?
microphone,
Oh,
Charlie.
sorry. Just to provide a little bit, I'll answer your question. Just to provide a little bit more detail to what Lee has said there. Because of the focus and the piece of work that we've been doing with Swansea Bay over some time about the what was the HAZU, which are now being called the CRSCs, we had to rapidly look at what the impact would be for the Carmarthenshire residents for the rest of the pathway, because it's only the Carmarthenshire residents that live within the allocated time frame that we felt was acceptable to travel to Morriston for that first few days of care. So we now fully understand what the impact and what the financial impact and the investment that would be needed to improve, to get that A-level quality for stroke patients in Carmarthenshire. Just to provide a bit of assurance that the same standards are now being applied as we speak to Ceredigion and Pembrokeshire. So it's not that they've been left out or forgotten, but we needed to do the Carmarthenshire work in order to be able to have an assessment and a discussion and consideration of that CRSC business case. So that was just to provide some assurance on that. What that paper very clearly points out for Carmarthenshire is a stepped improvement approach, because what we've discussed at length at exec team when also taken to SDOC was that in order to support the CRSC, we'd need to put the rest of the pathway right. And the stroke redesign work has never, ever been about saving money or cost savings. We've always known that to get to that standard that's a nationally agreed standard, we'd need to invest significantly, and it is a significant investment. So Lee's pointing out that we've successfully had Welsh Government agree that we can use the new AHP funding for the community to put ESD in, and that's across the Health Board, that's not just Carmarthenshire. It won't fully meet the requirements, but it'll put about 75% of those requirements in. So I'm really pleased about that. So as long as we can recruit, we will start to see a step change improvement from that piece of work. But it very clearly then points out what each next phase, as recommended by the team that have been working on this, what each next phase would be. So one of those things which will be taken forward through the clinical services plan is a review of the inpatient infrastructure, because there is a benefit, potentially a quality benefit associated with that. But then further pieces will require investment. Now, we have considered that specific withdrawal of the Carmarthenshire local authority funding within that paper. It's not the highest priority in all of the pathway that we would need to improve. But I think given the conversations that we've had this morning, the executive team did debate this at real length, and we find ourselves in a position at the moment that to invest in the stroke pathway in any element of it is actually very difficult to do at this point in time. The work is done. The work will be done for Pembrokeshire and Ceredigion very shortly, so we will understand what that phased approach is and what the investment will need to be as and when we feel we can make that. So I don't think it's not necessarily bad news in that we agree in principle that this is what we need to do. But I guess it's there waiting now for the time, when the time is right, to make a decision that we can start to invest. So we have taken it into account, but we haven't addressed that as yet.
Thanks, Alison, really clear. Steve?
Yeah, firstly, just wanted to thank Alison for the really detailed work, and we have had a lot of debate at exec team about what we can do with the national money that we've got to get the biggest benefit for our patients, knowing we are starting from a quite low base on some of these things, and doing that across, as Alison said, across the whole health board. I have had a discussion, we've had discussions with Swansea Bay about their desire for us to sign up to the I never get it right, the HAZU, the thing that's not called a HAZU, because clearly they're keen to get commitment on that. What we said is we are very committed in principle, but given all of the challenges that we've got, not least our ability to invest, it's difficult to sign up to a specific timescale around those things at the moment. So we will be following that up with a letter formally setting out our position to Swansea Bay, but I would reassure the board that we know it's a really important part of the system. In fact, we want it for all of our patients in time. But at this stage, given everything else we know that we're dealing with, it is quite difficult to commit to a specific timescale with money attached.
Thanks, Steve. And I understand this has also been debated in full at SDOC.
Yes.
Yeah.
The last meeting, which
Yeah. So thank you.
Chair.
Thank you. On that basis, the board happy to accept the recommendations and thank everybody for the work. Thank you. The next item on the agenda is the board assurance framework. And I suspect that is
Yeah,
you,
take
Jo.
that, Chair. So thank you, Chair. So since the November board, all the committees have received an update on elements of the BAF. And in particular, we've been doing some work as an exec team in terms of the outcome measures, and there's more work to do on those, particularly in relation to the population health measures which are under review. All the principal risks which are in the paper have also been reviewed by the exec team, by the individual execs and by the wider exec team. And I'm not going to go through the detail, Chair, but page 4 onwards does give you an update in relation to progress against each strategic objective. And you'll see from that that each of the planning objectives currently is being reported on track. We will need to change the BAF if there are, as we've discussed earlier, any slowing down or any pausing of any particular planning objectives chairing year.
Thanks, Jo. I think this is becoming more and more useful as it is maturing. It's very clear. Thank you, Steve.
Yeah, just on a general point, it is quite difficult to keep our eyes on this with everything else that's going on at the moment. I would commend Jo and the team who we have regular exec team discussions, just one last week around the measures. I think particularly the measures we need to continue to think about whether they're telling us if we're heading in the right direction, both in terms of their timeliness and their relevance, and that's quite a challenge. But we knew that when we set this out. I guess I would say, despite that, our need as a board to keep our focus on that strategic direction now more than ever is going to be really important, because we need to ensure that whatever decisions we make in the short term, we continue on with the mission in the long term wrapped around those 6 strategic objectives that we felt were really important to our local population.
Absolutely, thank you. So is the board gains, Anna?
Just a quick question, Chair, about the interdependencies between these risks. We assess the risks each in their own right in basically a long list. Are we confident that we've got the ability also to spot the interdependencies between these risks? So if one goes out, potentially that knocks another one out somewhere else in the system. Are we confident we've got what we need in place to spot those interdependencies?
I think so, Anna, because Professor Clare chaired the last session on this. And that was one thing that Phil raised as part of those discussions, and actually looking at some of the owners of the risks as well, where one could impact on another. And we particularly had a debate about leases in terms of workforce and some other areas. So we might not have got it 100% right as yet, but it's something that we certainly discussed at the last session.
Thank you. Thank you. Thanks. Thank you very much. Is everybody happy to accept the recommendation? Many thanks. We're now going to go on to the implementing Healthier Mid and West Wales strategy. And Lee, that's you.
Thank you, Chair. So there are 2 papers here. One is the general update on the strategy, and the second is the specific update on Kilcacaran as requested at the last board meeting. So firstly, on the Healthier Mid and West Wales update, there are a few key points set out in the paper, and so I'll just draw out the most important aspects for board members to be aware of at this stage, recognising that there's an awful lot of work going on between board meetings. So I'm going to just summarise briefly, but it will understate, I guess, the level of work being undertaken. So the clinical strategy review, first of all, Phil referenced that earlier. I spoke at the last board meeting about delay in that because of procurement challenges within Welsh Government. I'm pleased to advise board that has now been commissioned and is indeed underway. The report says that we can expect a report by mid-August. The latest information from Nuffield suggests that's likely now to be close towards the end of August, for board members to be aware of. There are visits planned next week by Nuffield and a virtual workshop to be arranged. So there's a lot of activity going on in relation to that, and some positive working with Nuffield Trust. The work on the SOC remains on track. So as noted in the paper, 4 of the 5 sections are now complete in draft form, and the final section on the financial case is to be completed shortly. The SOC, of course, will be subject to revision depending on what comes out of the clinical strategy review. So board members just need to be aware that the timescales are then going to be very tight for what we'd originally intended, which was to take the SOC to the September board meeting, particularly if we want to allow time for the programme business case to be endorsed by Welsh Government first. So that's a discussion for us to have ahead of that meeting. But just to flag, that is now very tight, obviously, as it was always going to be, but it's particularly tight now. The land consultation, we've got an update on that. We've had some very good engagement and responses from staff and the public. As we've reported previously, I think it has more than just a conversation about the 3 sites and the 3 options for our sites. It's been a very good opportunity to re-engage with our staff and our public about the strategy, what we're hoping to achieve through it, so we can hear what's important to people, where they have concerns, and obviously for us to provide some reassurances to those concerns as well, which I think we've all found very useful. A report is being compiled on that work, that feedback at the moment. It should be available in the next couple of weeks, and we'll provide that to board members ahead of the board discussion in September. So we've got time to consider it ahead of that discussion. The paper also provides a brief update on each of the community schemes that we're progressing. So I won't go into those, but obviously happy to answer any questions. The one exception to that is the Kilcarran paper that I just referenced earlier. So we've board members with long memories will be very familiar with the work that's gone on with Kilcarran. Previously, the project that we're developing in partnership with Ceredigion County Council, that unfortunately had to be suspended in December 2020 following the withdrawal of the Housing Association. So the paper provides an update on the activities undertaken over the last 12 months, and then the next steps, in particular, the intention to issue a new tender in September. And Eldeg's here, who's been leading on this with Peter Skitt, should we have any particular questions on that item.
Thank you very much. Open for questions. Telly.
Thank you, Lee. It's really on page 2 about the number of completed consultations with the public and with staff. And are ORS content with only 842 responses, or is that, I'm just intrigued, is that a good number, or could it be better? I'm just concerned that we are using that as a reflection of people's views.
I'm happy to give an initial response. I don't know if you want to add anything, Alwena. So I would say that is a pretty good response for consultation of this nature. I think it's worth bearing in mind that what we've seen through the discussions with the public is a lot of interest in the strategy and discussions about the strategy. Probably less interest in the specific sites, but obviously it has been an opportunity for people to ask questions about that and offer their views on it. The 842 responses is in relation to the people who have completed and submitted questionnaires, but we've obviously had a much broader group that have attended the sessions, and we've captured their questions and feedback as part of that. Plus then there's been a number of other events that we've held with town and county councillors, plus some very specific work with communities to really get into more qualitative discussions and understandings of people's views of what we're proposing and any comments and concerns in relation to that. So the report that we'll get from ORS will be much richer than an analysis of the numbers. It'll try to draw out some of those themes and the key points and they look to segment that then by geography and age group and so on, and what people's views were from a positive and negative perspective on each of the 3 sites as well. So I think, from my experience of all the conversations, there's been quite a strong degree of consistency in terms of the messages, both positive and negative. So I think it should allow us as a board to have a pretty good sense of what the public opinion is, recognizing that does vary depending on what group of people you're talking to at any point in time. So hopefully that gives some assurance. But Wenna may want to add to that.
I don't have much to add in a sense to what Lee has already said, other than to highlight the work that the community development and outreach teams have also done in engaging directly with some of our seldom heard from communities, and that has covered a very broad range of groups and organisations, through from going to Llanybydden to Dumbia, for example, and talking to Polish communities there, through to working with homeless organisations and people with learning disabilities. So there's been quite a broad engagement, not necessarily that is reflected in the 842, but it's reflected in conversations and thematic feedback to RS. So thank you.
Thank you.
Just on that specific question, and it's no reflection, because Alwyn, you've said the consultation is very broad. There were only 26 Welsh online questionnaires. Just from the language point of view, it's most probably, but it's very low in comparison to the 842. But obviously, that's just an observation.
Yeah, thank you. Alwyn.
I think it's also just to add probably to that comment, in the sense that when it comes to people completing things in Welsh, it's quite a reflection on individuals' confidence levels in being able to communicate. We see that time and time again. So as a health board, we have a role in ensuring that we build people's confidence and making sure that people are comfortable in using the Welsh that they have. So that could be completing a questionnaire, and if you have English words that creep in, that's fine, that's good. So to encourage people to use the Welsh they have.
Isn't it? Helen.
Hi, sorry, just to come in on that point, some people stakeholders would have written into rather than fill in a questionnaire. So I just want to make that point that it's just not the questionnaires. You would have had written responses to the consultation as well.
Thank you. Eldeg, in relation to Kilcarran, there was a market appetite being tested in Meet the Buyer without breaching any commercial confidentiality. Is there how did you sense the appetite out there?
There was certainly 3 or 4 sort of interested parties interested in working with us, but again, until we actually put the tender out and see what responses we get, it's difficult to know whether that interest will actually sort of translate into tenders being submitted.
Okay, thank you. Any other questions? Ansel.
Yeah, thank you, Chair. Since the land consultation meetings, which personally I thought went very well, but it was some members of the public have approached us with concern in relation to Transport for Wales strategy in not funding a station at St Clair's. Has there been any ongoing discussions with that?
Yeah, it's a very relevant point, Ansel. So they are part of our transport group, Transport Wales. So we have ongoing dialogue with them, and obviously seeking to provide the best set of transport plans that we can for our region. And that's not just trains; that's obviously the buses as well, and then the train station is part of that. So very much involved in that discussion, and I think that will feature in part of our discussions in September, I think, because we've recognised in the consultation document and all the documentation we've provided today that access to a train station may well be a relevant factor. Whether it's the deciding factor is another matter, or how much weight we put on it is for us to consider, but certainly we have seen it as an important factor. So we are continuing to engage with Transport Wales on that.
It's great to see the progress with the community schemes, the integrated care centres, wherever we're calling them. Is there any risk with those in relation to capital or funding in the light of the conversation about the financial envelope in NHS Wales?
Yes, so we've got we have been successful in securing some funding as noted in here for the business case development of some of those key schemes. So that is positive in that we're now accessing a different source of funding. If you see reference the integrated and rebalancing capital funds. So that is to our advantage and allows us to at least progress the business case and planning processes around that. Clearly, though, once we get to a point of full business case and the totality of the capital ask, that is all part of then the 1.3 billion that we've set out in the programme business case, which will inevitably be a challenge for Welsh Government to fund, at least in a short time scale. I guess there's always a question about how you phase these plans.
Okay, thanks, Lee. Any other questions? The board's happy to accept the recommendations in respect of both the papers. And Elder, thank you for coming with that particular paper. So the next item on the agenda is the improving, or shall I go on to the SARC, yeah? Because Eldeg's here.
Okay,
yeah, of course. Thanks for reminding me, Lee. If we go straight to 5.1, the Sexual Assault Referral Centre, I understand this has already been scrutinised at committee level.
Into SDOC, Chair.
SDOC, yeah. So if we could just, we've read the paper. In fact, it's gone through scrutiny nationally and locally for quite some time, hasn't it? But I will hand over to either you, Lee, or Eldeg.
Yeah, I wasn't going to add very much, Chair, other than to say that obviously we're seeking board approval for the submission of the business justification case, noting that the capital costs a budget at this stage. That was the point I just wanted board members to be aware of, and the development of the fully tendered costs will be undertaken following receipt of Welsh Government comments. So the case is seeking investment for obviously a very important infrastructure development in partnership. So as you said, it has been scrutinised through SDOD committee, so I'm happy to take questions, but that was all I was going to say as an introduction.
Okay, thank you. And questions? I feel like I've been part of this journey for years.
You know, regarding the paper,
Yes.
delivery arrangements, is it kind of achievable March 25?
So that is the timescale that the programme delivers up to. That is obviously quite a tight timescale, but we need to work to that because of the accreditation. So I think our level of confidence at the moment is that that can be achieved, but obviously it is a tight timescale for us. I don't know if you want to add anything to that, Ellen.
No, that's in factoring some time for Welsh Government to review and scrutinise the case, and if that goes to the timeline that we've allowed, then that's the project's deliverable within that timeline.
Okay,
good, thanks.
And bearing in mind the financial situation, can we afford consultants? Which is one of the, we're being asked to approve the use of professional services consultancy to deliver the project.
Yeah, so that's capital, not revenue, and that was part of our discretionary capital plan for this year. We had originally paused that funding as part of the issues we mentioned earlier about the firework, but we're at the point now, I guess, from the conversation we had with the Welsh Government on Friday, that we can then reinstate that. So I think obviously we've got risks around the wider capital, but for the time being, we're able to proceed with that.
Good to hear, thank you. Any other questions? Okay, well, massive thanks for all the work on all these projects, Eldeg. And thanks for coming to the board, and I'm sorry to delay you. Was the board happy to approve the recommendation to note the development, approve the submission of the BJC to Welsh Government, approve the use of professional services from the capital budget, which is just being replenished through the fireworks, and note the capital costs included in this version of BJC are based on budget costs, and the development of fully tendered costs will be undertaken following the receipt of Welsh Government scrutiny comments. Once the costs are obtained, they will be submitted to Welsh Government for review and approval. Yeah, thank you so much. Diolch yn fawr. Okay. Catherine, would you like to come to the table? Yes, Louise, come on. And Louise, would you please, do you want to come to the table? Okay.
She said she was going to sit at the back. And just
And we might try again. We'll see. Okay, so the next item on the agenda is the Improving Service User Experience Report. Over to you, Mandy.
So if I can start by introducing Catherine Lambert, who's our Arts in Health Coordinator, and this is what represents a team, one whole-time equivalent, although we're very fortunate that we've also got some administrative support to help Catherine now. And I think you'll realise the value in having that extension to the team when you hear about the wonderful work that Catherine has been doing across the organisation. So I'm not going to say more than that at this moment in time. Catherine's got a presentation, and I will just then very quickly run through any of the patient experience report as well. So Catherine, over to you.
Thank you. Well, over to you, Catherine.
Thanks, Mandy. So hi, I'm Catherine Lambert. I have the privilege of being Hywel Dda's Arts and Health Coordinator. So thanks ever so much for inviting me here today to just share a little bit of our experience so far. At the same time, we've got some pictures of some of the work that we've been able to achieve over the last year, and a picture there of my colleague, Dr. Kath Jenkins. So if you'd like to just have a look at the screen as well, you can just get a little bit of a flavour of some of the work. So I took the role up as a job share with Dr. Kath Jenkins in October 2021, she's a practicing GP in Morver Lane Surgery. But together, as Mandy says, we're appointed as one full-time role with funding from the Arts Council of Wales based on a memorandum of understanding between the Arts Council and the NHS Confederation Wales, with a vision to put the arts at the heart of service transformation for healthcare. We work within the patient experience team under Louise O'Connor. At Hywel Dda, our role has been to promote and encourage the use of arts in healthcare right across Hywel Dda for the benefit of our patients, staff and communities. Also, as you entered in today, I hope you've had a chance to see some of the artwork, Dose of Art by the artist Nathan Wyburn, which is a piece of work that we're hoping to tour over the Health Board in the different healthcare settings over the next couple of years, that came out of a request really, and a passionate member of mass vaccination staff, Gemma Brown, who approached us with a vision to create an artwork out of all the lids from the vaccination vials from the COVID-19 vaccination programme, to honour the incredible efforts of staff and volunteers involved in that programme. So if you haven't had a chance to see that on the way in, then I urge you to have a look. Just briefly, I've joined the Health Board after 20 years of working within the arts sector, mainly for arts charities, but also as a freelancer, a funder, commissioner, art director and producer. My background's been in the visual arts, and most recently I was director of Span Arts, which is a community arts charity based in Pembrokeshire, where I established a vision for arts as social change. And it was here I saw firsthand the incredible, powerful role the arts have to play in improving the lives of individuals and communities, and to see there was huge potential to make a difference. The role of the Arts and Health Coordinator at Hywel Dda is a brand new role. We're part of a national team of Arts and Health Coordinators working across Wales, but in some health boards, that role or a team has grown with that kind of history of about 10 years of practice. But at Hywel Dda, it's a very new role, and we're still at the early stages of our journey. We were able to get started, though, with an incredible set of introductions from Louise, and also the Health Board commissioned a mapping study to understand the work that had already been taking place over the last number of years, which was an invaluable starting point. But basically, over the last 18 to 20 months, we've been overwhelmed really by the need, but by the interest and the welcome and the appetite from healthcare staff, patients, partners and communities right across the Health Board. And having now spent 20 months working in the NHS, I'm more convinced than ever that the arts has an incredibly powerful role to play in healthcare. Everyday life is not quite the same as life within the NHS. On a daily basis, healthcare staff and patients are genuinely dealing with life and death, and I feel that it's here where emotions run high and the needs are so deep that the arts can be at its most powerful. The arts can help to comfort, to soothe, to bring joy, help us to express ourselves, to celebrate, remember and reflect in a way that's evidently needed in healthcare. The arts essentially help people to make sense of the world and help us to understand ourselves and our place within it in a way that's utterly vital when we're at our most vulnerable and questioning what it all means. The arts offer a genuinely person-centred approach to healthcare, and we can see firsthand the powerful role that this can have on individuals, which is often breathtaking, and staff and patients can be often moved to tears when witnessing the change in a patient as part of an arts intervention. The welcome and support from other colleagues has been really amazing, and I've never really had the chance before to work with such a large number of dedicated, intelligent and passionate professionals in my working life. We've also recognised that the role of the arts within healthcare can be a useful vehicle for affecting change and breaking down conventional ways of doing things and help us to think and do things differently. As I say, I've had the incredible opportunity to work with staff right across the health board to look at ways to help improve the patient experience and to support staff. So we have been able to pilot programs of work such as a partnership with specialist CAMS in terms of improving mental health in children and young people known to CAMS. We've been able to bring live music into intensive care settings right across the health board. We've been able to provide interactive singing and visual arts for our inpatients living with dementia and projects which can aid recovery and help to build confidence for people in moving back into the community. We've also been looking at improving healthcare environments through using the arts to help create therapeutic healthcare spaces, places which feel like a kind and healing environment that can aid recovery and improve the patient experience and reflect the level of care that healthcare staff can provide. For example, we've been working with the capital and clinical teams from the bronchitis chemo project to engage with staff and patients and to understand the role of art within that project. We're working closely with others and hoping to take the learning and development within that capital project to other environments and hopefully to the new hospital. We're also hoping through that work to support the health board in its biophilic vision and to encourage partnerships between art and nature. Working with staff has been also an incredible learning journey, but with thanks to NHS Charities Together funding, we've been able to pilot a programme of creative activities for staff wellbeing. By being new and maybe a little bit naive, we've been able to experiment and see what works and try new things, do things differently and see what happens. Again, this has been invaluable, and I've been astonished really, not just by the take-up, but how fragile healthcare staff are and how raw their emotions are, but also how quickly the arts and artists and musicians and storytellers have been able to unlock that staff member and help to provide a powerful moment of respite and renewal. A key part of our work has been working in partnership. We're working with healthcare services and teams right across the health board, but also Public Health Wales, the third sector and the arts sector too. We're working with local and national arts organisations and have been able to bring in other finance into programmes and projects. So our aim really has been to show that we can bring in and generate far more arts and health provision than our posts cost the health board. For example, we've been able to bring in about £300,000 of funding just since we've started and are currently working on our next batch of applications. So where next? We hope to build on this amazing start. As Mandy says, we're growing as we have been able to appoint another member of staff as an administrator within the team. And we're working towards building a movement really across our Hywel Dda that makes art and creativity everybody's business. We're developing the Health Board's first ever Arts and Health Charter, which is not only a first for the Health Board, but I believe is a first for health boards in Wales, as there are arts and health strategies being developed across other health boards. But we hope to publish a charter that sets out a vision for putting creativity at the heart of healthcare. And we hope to bring that draft to you to consider in the autumn. Thank you.
Catherine, thank you. Do you know, you talk about the raw emotions of healthcare staff and what it's doing. It's really uplifting for us as a board when we're looking at all the challenges to see something as positive and as beautiful as what you're doing with your colleague and with everybody else across the health board. So thank you for that. I'm going to open it to any questions or comments from colleagues. Phil.
So I'm a great fan of this, as you know. So and it does really link to the social model of health and well-being. And I suppose arts can be really stereotyped as sort of painting, as I would have stereotyped it before people like yourself got in my head. And I have this hunch that the sort of the kind of work you do with patients with dementia around singing and could perhaps have more of an impact than probably a lot of the medical input that we put in. And it's the trouble is often though that it's really easy to have a mechanistic approach to measurement around you give someone a tablet and see an outcome, whereas actually with the work that you're doing, it's quite difficult to apply the same sort of medicalized mechanistic model of evidence building. So, but I'd be really interested to see this art and creativity at the heart of healthcare work that you were talking about, and thinking about how we promote it and build an evidence base that's that kind of works for those kind of interventions. So I think we need to think about that. We've also, by the way, as part of the social model work, we've supported Preseli Cares. She's doing some work lottery funded with PAVs in Pembrokeshire and Newport and Preseli to work with Span Arts, and they've been successful in a bit of funding there for working in the communities there. So yeah, looking forward to seeing that report in September and working with you on building that evidence base.
Brilliant, thank you. Rodri and then Judith.
Yeah, well, that was very inspirational, and thank you for that presentation. And congratulations on being pioneering really in the arts and health charter. So that's a good one for Hywel Dda. I'm just thinking with the work that you're doing, and obviously this is a new. It's just, are you talking to the other health boards? I know you've said that already, to get what works better or works well, or kind of just to learn to grow the team that you'll have here, and just because those ideas we've seen there, they're inspirational. But I'm just thinking, are they doing other things that you've learned or you're picking up from other health boards?
Yeah, so as a team, really, a national team of arts and health coordinators, we do come together very often and sharing experiences and learning. We're also all part of the Welsh Government cross-party group on arts and health as well. And so again, sharing learning and experiences and evidence base there. It's kind of very fast and exciting moving area of practice and a growing evidence base. So where we can, yes, we're trying to learn from each other and to share our learning as well.
Thanks.
Judith.
Yeah, huge thank you, Catherine. I've had the pleasure of seeing this before. Congratulations on the money you've attracted. That is phenomenal. You know, for the size of team to attract that investment, you know, congratulations. I think it's great to see having Dr. Jenkins there as well with that primary care GP input to it, to think about the out of hospital impact of all of this. And Marie, you were there as well. We went to the Children and Young Persons Sanctuary, which, you know, again, has had a huge input from an artist called Lloyd the Graffiti in terms of the artwork, but also colours. It all brings together with the biophilic design, with the, you know, green space. You just get a sense, and certainly talking to young people there, of how that the art and the colours and the nature make them feel better, as well as obviously the therapeutic input. So it is really important. And I just think it's great to have this here at the board, and how we can really harness the excellent work you're doing, not overwhelm you and not try and get into an area that I certainly don't know anything about, but it's really brilliant. And it's good to see how it can all link together. So thank you.
Ali.
Yeah, thanks, Catherine. And, you know, I'm just echoing what Phil said. I'm a massive fan of this piece of work as well. And I seriously don't think we should underestimate the impact that this has. We have a very small number, I'd say on one handful, of professionals in this organisation that are within the arts therapies. So art, drama, music therapists. I think we have less than 5 of them. They've been trying to do this clinically with patient groups for a very, very long time. And I think what this has demonstrated is it's not just individual, very small niche patient groups, but actually the impact that this can have on both the mental well-being, but then as a knock-on, the physical well-being of any patient group and staff. And I personally attended one of those beach arts sessions, and it was fantastic. It was just an opportunity. I thought, well, that looks like a bit of fun. And it was really fantastic to link with other staff and have that conversation about how they were feeling in work, how challenging it was, and just to switch off for a couple of hours. So excellent work, keep going, well done. And I just implore everybody to not underestimate what the impact of this is.
Absolutely agree. Yeah. Adrian.
Thank you. Yes, fan evidence has been emerging for a decade now and really building. But on that, on similar point to Phil's, are we evaluating it properly, robustly? Because it can be more difficult in a soft intervention such as this. But we do have in Wales academics who have really strong expertise in evaluating qualitative interventions.
Yeah, I think that we are working quite closely with the research and innovation team who are working with us to support us on various projects that we've had funding for, but also we're trying to establish an arts and health research group and having conversations with higher education partnerships and so on and so forth as well. So absolutely, but there's a lot more work that needs to be done there.
Tatiana, you might be able to share some of the experts.
Yes,
to help.
Happily link in that. Thank you.
Great. Catherine, massive thank you on behalf of everyone. I've been with you on the journey since you started, so it's great to see the success and the confidence. Just want to ask you one question before we finish this part of the patient experience report. If you had one wish, what would it be to improve this?
I think that, yeah, I suppose the challenge really is around the scale of the need and the scale of the potential. So to find a way really to respond to that opportunity, to respond to that scale by investing in the agenda really moving forwards, I think would make the biggest difference.
Okay, so we keep an eye on the others as well, because others have got much bigger teams, haven't they?
Yeah.
Okay, the dream for the future.
Thank you.
Many thanks, Diolch yn fawr. Thank you. And I think Mandy's going to go back to the patient experience report.
Absolutely. So just to add my thanks to Catherine, and I think she underplays her expertise in this field.
Yeah.
She's incredibly humble in this space, but actually she's led an awful lot of work across Wales as well. So just to say that, and in terms of Dr. Kath Jenkins, unfortunately she's finishing her contract with us at the end of this month, I think, Louise, yeah. And that's because of the clinical pressures that she needs to go back into primary care to deal with. That doesn't mean to say she's not continuing to have an interest in this area. So I just wanted to clarify that. But Catherine has kindly taken up some additional hours for us, and with the aid of the additional support that is being funded, and we are going to be having a further discussion through charitable funds to look at, because of the impact across patients and staff, how we can further in support and enhance the service going forward. So thank you for that, Catherine. In terms of the patient experience report, I won't be reading through it. You'll be very pleased to hear, but it's just to pull out a few highlights. This is for the period from the 1st of April to the 31st of May this year. I think it's important to identify that we've had, out of the many thousands of surveys that we make available to people, we've had just over 5,400 to be exact, that have been returned to us. And the positivity rate, and it has already been picked up in discussions earlier today, in terms of how people who use our services rate our services based upon their experience, is high. It's 95% in terms of positivity. That does not, however, as Louise always knows I say, take away from the experience of the 5% who didn't have a positive experience. Our complaints response time still rests at about 67. It's really stubborn. I'm trying desperately to get it higher, as Louise knows as well. But we're working hard on that, and we're working hard with the operational teams because it's in their hands in many respects that lead us to have the percentage response rate that we do. Key themes, however, continue to be clinical assessment and treatment, delays in diagnosis and communication. And we've already heard earlier today about the importance of communication and how we need to do further work. Predominantly the complaints around, in the context of communication around appointments and how we communicate with our population, and also waiting times as well. So you will be aware, and we've referenced it previously, the work that Lisa's team are doing around making a difference. And I am pleased to say that even though, and as Anna called out, communication is so important, we need to look at what more we can do. We have seen in the last 3 months a consistent improvement in our responses that reference communication as an issue. And I am hopeful, it's like all things, because this is about culture, it's about behaviours, and it's about staff understanding the impact that they have on individuals in how and what they say to them, that the programme that we instigated last year, I think, Lisa, is actually coming to fruition. That doesn't mean to say that's the only mechanism we need to use. And what I can say, and certainly it was evidence from the walk around that I did myself earlier this week, the Civica system that, again, you've heard me talk about repeatedly over the last year or so, actually, about how we're using this national system to better capture patient feedback, is actually being rolled out, or has been rolled out in many of our areas. And I saw it being used firsthand when we did a walk around this very week, how the teams have embraced the system, are pulling off their results, are using the feedback that they're getting, both positive and negative, through their team meetings and the discussions that they're having, and importantly, beginning to display it in public places for the public to see. You said, we did. It's not everywhere yet, but we are getting there. And that's a significant improvement. And I think that general culture of wanting to improve is really being embedded. So that's the one thing I want to just reference, because it's probably not as visible in the report. The other thing that you'll see is in the report, particularly around page 10, is around hydration and A&E. And I'm constantly frustrated that I get feedback that patients are not systematically and routinely being offered hydration opportunities whilst they're waiting for what are long periods of time in our A&E department. The nutrition and hydration group will be picking this up to look at what more can we do. The heads of nursing hear from me on a regular basis about the provision, automatically offering water as a bare minimum. And there is some work going on looking at the vending machines that have gone in. Not everybody comes to A&E now with cash in their pocket. And in fact, increasingly, we are encouraged to use cards, and yet we appear to have put in cash reliant machines. So that is something that our team is looking at the moment. The patient story that we have as well also focuses around nutrition and the impact that the dietetics team can have when they get involved in nutrition care. So good nutrition isn't just something that we focus on in our hospital setting, but actually how can we better improve nutrition, particularly in this challenging social economic situation, to support our communities to have good nutrition in their day-to-day lives, because that has an impact. Again, we were talking earlier about pressure damage. If you aren't well hydrated, you aren't well nourished, then you are more likely to be victim to a pressure ulcer. So all of that we're looking at again through the nutrition and hydration group. Pain management has again sadly featured in terms of some of the feedback that we've had. And in fact, a number of our pain leads are going on a conference shortly to look at what more we can do. It's a national conference, what more we can do in the area of pain management. There was one other thing that I was going to call out to you as well, and I can't remember it, so I'm sure that you'll ask me questions. But it's just to say that I think it's duty of candour, sorry. Duty of candour, you'll be aware that we have a new duty around duty of quality and the duty of candour. In this board report, you are seeing for the first time publicly our position in terms of our compliance around duty of candour. Bear in mind it was introduced in April. You will see that we've done an enormous amount of training, and although again the numbers don't look high, that has been to groups of people as well. So we haven't necessarily captured everybody who has been in the room when we've been doing them. The team have been out doing an awful lot of awareness raising, and the quality assurance team have made themselves available and are heartened by the number of increased calls. I didn't think I'd have a team saying that, but increased calls that are coming through from operational teams, just checking and seeking advice about duty of candour, whether it applies, whether the threshold has been triggered, and what more they need to do. Here we can see that there's 4 out of 22 that have complied. That, again, is something that we are looking at to make sure that teams understand. It's not the corporate team that have to have the conversation with those that have experienced harm or are experiencing moderate and above harm. It's actually the operational teams, and I'm sure that it is being done more than we appreciate. It is possibly a recording issue, but again, we're going to have to work that through because it is new for people in terms of the capturing of it. So we will be continuing to monitor that progress through the internal implementation group that I'm running. I'll stop there and take questions.
Thank you, Mandy. Questions?
Not quite a question, Chair. It's just I took over from Paul Newman in relation to chairing the Listening and Learning Subcommittee, and we met, I think, a few weeks ago. And what was pleasing to see was this approach from the operational team who attended the committee in terms of their candour, in terms of saying, oh, well, yes, we didn't do that well, and we've learned from that. This is what we're going to do. So that, I think, was very interesting from my perspective, was the fact that clearly lessons were being learned, because often we don't hear that at this board, but clearly it is having an impact. And certainly I witnessed that as part and parcel of the committee.
Yeah, it's good to hear that, Chantal, and I was chairing that before Paul, and it was the same then. So it is a cultural thing of that honesty and openness in that committee. That's good. I'm going to bring in Ali, then Anna.
Okay, thanks, Chair. I just feel it would be remiss of me to not comment on the patient's story. I heard about this gentleman's experience a couple of months ago, and I was really keen that it came to the board because it's a very powerful story. And I have to say, this isn't a criticism, but I don't think the words on the slide actually convey the difference and the difference in this individual gentleman's outcome had we not, and I am so grateful that the board invested in tackling malnutrition. And you'll recall that we were looking to focus just on the acute sites, but I have to say the independent members really pushed for tackling malnutrition in the community. I'm a dietitian, so I'm declaring that by background. In my clinical career, I've never seen an adult weigh less than 4 stone, which is what this gentleman's situation was. And I'm absolutely in no doubt, if we hadn't invested in that service, he would have been admitted. At best, he'd have been in for a very long period of time. He probably would have deconditioned further because of being in hospital unnecessarily. At worst, he probably would not have gone home. In fact, I'm fairly confident he would not have returned home. And I just think it's a really good example. We talk about the what, the so what. This is a real example of the difference that we made to one individual because we invested in that service. And I am very grateful and really pleased that it's here today.
Thanks, Ali. Thank you. You want to comment on the same point?
Yes,
then I'll bring
it's
Anna.
just to apologise, sorry, that the links for the stories weren't actually inserted into the report. It's a technical issue that we're addressing, and Louise and the team are going to be working with our awareness team to look at how we can make sure that this doesn't happen again, because I think the power of hearing the story is really, really important. So apologies for that.
Thank you. Anna.
Thanks, Chair. Yeah, I'm glad Ali's brought a spotlight to that patient story. And I think there is a question sort of further up the chain around, as a community, how are we in a position where a man in that kind of condition was left unnoticed until he fell? So that's a broader consideration as we think about what we mean by a social model of health and everybody playing a part in community wellbeing. I did just want to mention a couple of things, though, without wishing to bring down the mood. And indeed, the good news in this, I think we do have to be careful about extrapolating the results within this sample to the total patient population. You know, there is a participation bias in this, and we know that there are, like every other healthcare organisation, families who are absolutely on their knees and not got time, energy, effort to make a formal complaint. So I think we do have to just be a little bit careful about saying that 95% positivity in this sample equates to the whole population. On that note, and I did just touch on communication, it's not the place to unravel it here, but I do think as a board, we need to really start thinking about a mindset around communication, particularly with carers of very frail people, whether they are elderly or otherwise. Carers really can be the invisible member of the MDT, and we simply wouldn't accept communication with our professional colleagues to be as poor as it often is with carers who leave their relatives in the care of our services and then find it exceptionally difficult to even get a phone conversation with people who are looking after them. So I really do think we need to up our game on the communication challenge that we face, to shift our mindset, to think beyond the training, to think these people are a crucial part of the MDT, a crucial part of our long-term strategy, the viability of our NHS services, and we need to do better on getting better at consistent communication with people who prop people up for all those days of the year when we're not involved. And that would include some very practical things. I've raised before the black hole of Glangwili in terms of mobile reception, and it's resolved if you have a smartphone and you can connect to the Wi-Fi. But for very elderly people, a regular mobile phone is enough of a challenge. If we could simply solve the mobile reception in Glangwili, we could seriously help the communication issue with families. So not to unravel any further here, Chair, thank you for indulging my speech about that, but I feel very passionately about it. And I'm so disappointed that time after time, we just don't seem to be able to shift it.
Yeah, to the speech which passes.
Can I just, in terms of a couple of things, we did pick up the issue around the Wi-Fi connectivity. We do have some black spots, and Hugh's aware of that. And Anthony, in fact, I spoke to Anthony very recently following a recent board round to look at, can we just recheck and make sure that there aren't any spots that we're not aware of? So Anthony committed to do that. And in terms of the communication, the one thing I would flag is that we've been doing a piece of work, it's mental health and learning disabilities, and it's on the back of the HIW inspection report that we had following the lessons learned from the CUMTAF report. And one of the things there is about how you contact and communicate and engage with carers of people who are ill and in need of services and care, and not using the barrier of confidentiality as a reason why not to communicate. So I think there's going to be some significant learning that we can use through that mechanism, because they've already got an improvement plan in place to look at how do we lift and shift any of that into the acute sector, so that people absolutely see the relative, the carer, as that integral member, as you say, of the MDT. At the end of the day, it's about shared care, and that's not just about the professionals involved. So couldn't agree more.
Thank you. Janet.
Diolch, Chair. Diolch, Mandy. As you would expect, my question is about communication through the medium of Welsh. And I'm really intrigued to see that we've got such a high percentage, I think it's nearly 73%, that patients are saying that they're not able to speak in Welsh if they need to. I'd like to understand the figures behind that, because as we know, Hywel Dda's footprint, a lot of our patients and staff and carers communicate through the medium of Welsh. So I'm really intrigued to see such a high level there.
So I think that actual slide is the patients themselves have said it's not applicable to them because they're not Welsh speakers. So the one thing I would say is repeatedly we're asked by media companies, can they come in and film and do work with us? And actually, the one area that I keep throwing them at is Glangwili, because in Carmarthenshire we have a high number of staff who are Welsh speakers. So we get very few complaints from Glangwili around, or Carmarthenshire actually, about the ability to speak Welsh with members of the MDT. In the other areas, we still have Welsh-speaking staff. In fact, I checked out on Monday as part of the walk around whether people have got the ability to communicate in Welsh, and can teams make staff available who are Welsh speakers if they haven't got anybody on duty at that point in time. So I think it's more how the patient themselves have responded, rather than it being it's not important to us, because we absolutely do. And certainly when I go around the wards, I frequently and increasingly hear Welsh being spoken. So it's not something we rest on our laurels about, but it is something that we do need to make sure that we promote and encourage it. And certainly even just the university in Aber now being able to provide significant amounts of the training through the medium of Welsh, certainly in Ceredigion, is going to boost the number of staff that we have able to deliver at point of care.
Thank you. Could I ask a question very quickly? The page number is 23, and it's one of the complaints in relation to a lady who's pregnant. I just wondered what the learning was from that.
So just to confirm, and I have double checked this is an anonymous piece of feedback. It's not somebody who's left their name, and certainly it's not in our formal complaints process. I have, however, had assurance that the team are trying to identify the particular case to see whether there's anything different or more that they can learn. I think one of the important things, not about this specific case, but more generically, is about the pathways that we have, the support mechanism and the communication that we have with our patients when they find themselves in these distressing situations. And what I can advise, having spoken to the head of midwifery this morning, is that they're changing their pathway, so that at the moment, if you were experiencing this sort of symptom, you would be managed through gynecology up to a number of weeks. The pathway is changing so that it will be through maternity services for anybody 16 weeks and over.
Yeah.
So that will enable the midwifery service to actually deal in a much more sensitive way with the individual.
Yeah, thanks, Mandy. Any other questions? Well, thanks, Louise, for leading this team, and Mandy, thank you for having it as your portfolio, your responsibility. The report improves all the time, and it's really important that we hear the voices and we keep learning. So diolch yn fawr, thank you both. So the next item on the agenda is Further Faster Together. I noticed that the Together sometimes drops off the national and sometimes come on, so we'll keep it. I think, yeah, we like it. We're together in this. So over to you, Andrew. And warm welcome, Priyan. So over to you.
Thanks, Chair. So I'm conscious of time, and I'm conscious that there's a lot of information in the papers, so I wasn't planning to say too much by way of introduction, but give an opportunity for you to get into some questions. There were just a couple of things I wanted to say, I think, contextually, that I think are helpful to remind us of. So if I take you back a year to when we launched our Transforming Urgent Emergency Care programme, you may remember that we had a subtitle to that of Frailty Matters. And actually, back then, we'd identified from our perspective as a health board that the core population group, if you like, that we needed to give some focus to in improving and having the biggest impact on improving our urgent emergency care system was the frail population. And we set about, at that point, redesigning and thinking about how we'd redesign our urgent emergency care system to address that challenge. I think it's fair to say, and Rian will tell me if I'm wrong, I know, but I think it's fair to say that the work we did in this space and have done in this space over this year have actually significantly influenced the national policy direction and position on this, and have led in many ways to the development of the Further Faster policy statement of intent in March, but also the ministerial statement on the 6th of June, which brought the focus back onto how the response and operationalisation of that response was to focus on older people and frailty. I think, and I'll come back to that just before I finish in a moment. So that for us, where the statement of intent and the statement from the minister is welcome, because actually it completely aligns with the programme and approach we were taking as a health board, and actually helps, I suppose, to formalise some of that together approach maybe that you were emphasising then, Chair. We had already agreed with the counties a need to work together on, with our local authorities a need to work together with us on this. But I certainly think that the policy, the statement of intent, injected a bit of more urgency into the need to agree collectively a set of commitments and approach to this ahead of the next coming winter. And that's certainly where we've been in the conversations with Carmarthenshire, Pembrokeshire and Ceredigion. I wanted just to highlight, because we talked earlier on around metrics on page 9 of the slide pack. There's a very detailed slide that shows the outcomes framework and all of the metrics we'll be tracking that cover our whole urgent emergency care programme, but also incorporate the metrics we'll be tracking in this specific space. And to that end, we've established, as I touched on earlier, the Integrated Home First group, which I chair, and is the deputy chair is the Director of Social Services from Carmarthenshire, but that's to provide oversight on a regional basis to our collective plan and progress in this space and the impact that our plans are having. So I'll probably start moving. I'll move over to questions. But the one thing I wanted to say is before, just so that I don't miss it before we finish, is I want to thank Rian especially for her leadership on this over the last year. Obviously, Rian was a county director with us for a significant period in an integrated role with Carmarthenshire before she picked up the SRO role for us for urgent emergency care. And as I said, the work that she's led and has done has not gone unnoticed. It has been spotted nationally, not just in this, but in an invitation for Rian to go and lead this piece of work nationally. So I wanted to make sure I thanked her for all the work on this. She'll be leaving us with a very good plan, and then she'll be on the other side of the table making sure that we're delivering it locally. And I've had several conversations with her about wanting to make sure we remain at the head of the curve in terms of progress on this. So I'll keep trying to maintain that relationship in the future. But I want to say, because it might be the last chance I have to say that in a board setting before she takes up her secondment opportunity.
Thanks.
So I'm happy to take questions, and Rian's here will be able to help with the detail as well.
And all I can say in the last point is there's still time to say no, Ria.
I was going to say.
You're sorry, and I mean that. Any questions, please? And we did have a wonderful board seminar, I think it was a couple of years ago, where you went through whole detail of the theory, and it's great to see the implementation. So questions, Judy?
Yeah, I'd echo that with Rian, and definitely there's still time to change your mind. Rian, as you know, I've seen the presentation a few times, and it is impressive. I suppose one question I have is around trusted assessor. I have picked up in my other role that there's slight reluctance to move to other people doing these assessments when you've had it done in a certain way. And I see what you've said about the expansion, but the setting up another group to look at it, the consideration of doing it just feels to me a little bit like delaying, or am I being overly pessimistic?
What I would say is, if it is delaying, that totally contradicts exactly.
Sorry, I can't hear you very well.
Can you hear me now?
Yeah.
It's a bit better.
Is that better? I'll project
Yes,
my
that's
voice.
better.
Great.
Well, I will say to that, if it is contributing to more delays in the system, that's contradicting what trusted assessors and the principles associated with it are for. There is guidance published nationally now
in relation to trusted assessors, and it is also part of the Social Services and Wellbeing Act in terms of an expectation, which really clearly identifies that the proportionate, this is not an assessment for social care or indeed for continuing healthcare, it's an assessment that's proportionate to the needs of that person at a point in time. And that point in time is where invariably a person with very complex needs who needs to get home in order to protect their well-being going forward has a quick assessment in terms of what matters to them, which invariably is that they want to go home. So it is a quick assessment that has to be undertaken by the person that knows that individual best. And invariably that person is the nurse at ward level and can also be the physio with the OT managing their responsibilities, which is part of their own professional assessments, will have the information to hand. What we have promised in terms of the Integrated Home First group that has agreed to those principles, and we're working towards having one electronic form that can be used by everybody across the 3 counties to make sure that we've got consistency, is that form is proportionate in itself, that it is not too arduous a thing to be able to do. And I believe if we do that, then any challenges that have been raised will have been answered.
Okay, thank you.
Thank you. Holly.
Sorry, it's me. I recognise, Rhian, that it's a West Wales slant, and I'm so glad that you're going to work nationally, because for me and for the community, I'm thinking of our Gwynedd and our Powys local authorities as well, and whether or not there is further work for us to do to reflect our service users coming from those local authority areas, especially into Bronglais and sometimes into Glangwili.
So if I go back to Further Faster Together, the statement of intent and indeed the discussion document which came out in December very clearly highlights that a frailty quality statement will underpin the development of a specification for, I think it's an outstanding health and care system for older people for Wales. And for us, it's that the quality standard has to underpin the development of that specification to make sure that we get that consistency across the whole of Wales. And I think it's something that we've spoken about regularly, isn't it? That our infrastructure across our own 3 counties might be differently, but what we've strived for in the Integrated Home First group is that each one of those building blocks have got evidence-based standards and principles which we would all expect to deliver. I'm quite confident that those standards that I'm talking about in West Wales will be the same as across Wales, because they are implicit in any national guidance and have also been recommended in peer-reviewed literature for the care of this population.
Thank you. Anna and Maynard.
Yes, just a brief comment from me, Chair. Thank you, to say what a fantastic piece of work this is. And I was particularly struck by slide 5. I thought the formulation of the issues that our system faces is absolutely fantastic. I put a load of ticks over it. I think it might be unprecedented in my more papers. If only we could be this clear about everything that we do. And I think we know that deep understanding of the problem we are seeking to solve is absolutely critical to impactful improvement. So just wanted to reflect that I think this bodes very well for what might come from it. Thank you so much.
Thank you. Maynard, or do you want the same point as it, Phil?
Well, it's on that slide.
Okay, is that okay, Maynard?
Yeah,
Phil?
no worries.
I wondered, one of the things often gets quoted is this 20 to 30% of emissions that could be prevented. And given the fact some of our assumptions for our strategy are based on that, I wonder whether, I realise this is tricky, Rhian, and we've got the benefit of you for the one last board, but I wondered where along that 20 to 30% of emissions being prevented are we, considering we've done some work? So have we prevented, do you think, 2% of them or 5% of them, or 10%, or have we still got 20 to 30% to go?
That is a challenging question for me to answer. I guess the fact that we are in the position that we have with a number of patients in our hospital beds at the moment who arguably could have been looked after at home is testament that we haven't actually done what we aspire to do in totality. There's an awful lot of things that underpin the reason why that is. There's a lot of culture change, mindset change, not least societal expectation in terms of what potentially we can deliver in the community safely compared to the hospital. What I do know from the data, as Andrew alluded to earlier, is that we are starting to turn the trend on admissions for that population group. I get asked very regularly, what does good look like? From my perspective, and this is my perspective, what good should look like is 100% of our moderately to severely frail, should be a planned admission, that we should have given everybody an opportunity to have a safe alternative in the community before they're conveyed. And am I confident that we've got there? At the moment, no, there's a lot of work to be done, but we are starting on that journey.
So you've avoided the percentage question. Can you guess?
Politics.
Have a guess before, so we've got
Nearer 20 to 30% still.
really. Okay. Maynard and then Adriana.
Thanks. Really echo the sentiments that have already been expressed about the work that's already been done. And as champion of older people, particularly pleased to see this. Just one comment, sort of concern, is strangely enough on what you just referenced, what should good look like slide, and the digital self-assessment and the tech side of things. One of my soapbox things is digital inclusion, and I know, given the figures in our that we've got a large number of over 75s, and 25% of those do not have access to the internet. So tech and digital self-assessment can be a concern, and I just don't want to lose sight of that population and make sure that we're picking those up in the work as it goes forward.
Yeah, absolutely. And it's something that we're very aware of. And part of the digital strategy, as we know, makes reference to that. And there are opportunities for us with existing digital technology for us to use different systems to enable not just internet connectivity, but also use of devices that are more user-friendly for that population group as well.
Diana.
Thank you. Echoing, great piece of work and no surprise, but sad that you will be leaving us and going to the national team. On percentages, Phil, and general on the outcomes framework for older people, forgive me if it is there, but I haven't seen, and for obvious reasons, having a joint organization very recently, I don't know the details, but one thing I can't see is falls and how we account for, particularly for falls after discharge, knowing that in percentage, very significant high number, 40% almost of elderly people that get discharged suffer a fall, and then that accounts for about 15% of unplanned admissions. So are we accounting, are we measuring, and maybe our assessors, are they doing something about preventing falls in the community? Thank you.
So falls is a huge piece of work that is aligned to that. I know Mandy's team are leading. There is a regional task and finish group around falls. So we have aligned this programme to that programme. What you see here is what I would say a very high-level outcomes framework with high-level process metrics that sit underneath it. There would also be subordinate data, which would include things to do with falls underneath all of that, that local county systems could include to support their reporting in terms of impact, etc. But they're not in this, but it's something that, we haven't formally met properly, and before I go, I'll make sure that I can take you through the whole range of that and the thinking behind it to make sure that it captures all of that from a wider population health perspective. But it's definitely something in there, and the standard associated with proactive care and urgent care definitely reflects the need to triangulate. So if somebody's had a hospital admission, the increased risk, and actually the so what, because they then become part of that high risk vulnerable population that we need to put monitoring processes in place for.
Okay, thank you.
Well, thank you very much. I'm going to go to the recommendation. There is a number of bullet points there. So two are to acknowledge the national expectation of Further Faster Together, and we're going to keep the name, acknowledge the current position locally. And the last one is to approve the exploration of formal integration of health and social care with local authority partners. Can we ensure we include the board secretary in that exploration if it goes further down the line, so that we are sure that we've got the right governance, which I know we will do. And is the board happy to accept the recommendation of the report? And with the board would want to wish you all the very, very best in your next stage, in your journey, in your career, Ian. Please be gentle with us when you're on the other side. And you know, there's always a very, very warm welcome if you wish to come back home and bring any further knowledge you've gained from being inside government.
I will.
So
However,
thank
I will
you.
always be my home.
Yeah, absolutely.
It's been a huge part of my career, and I'll always reflect back on it very fondly. It's where sort of I learnt my craft. So I thank you all for that and all of the support that you've given me in my career to date. Many of you have been along the list for a long time. Looking at Professor Clare there way back, but yeah, thank you so much for mine. Thank you. Thank you for your faith in me to lead, you know, an area of provision that is very close to my heart. And I feel privileged to be leading this across the whole of Wales. Not that I have a date yet, so it's all still, yeah. Thank you.
Thank you very much. Thank you. We're going to break for lunch, which I don't usually do, but there's been a packed agenda. So we're half an hour, and I'm sure the afternoon will go a lot quicker than the morning. I promise you that. Go and have some lunch and get some reserves of it. Get your energy levels up so we go for the next bit. Thank you.
No, I thought you'd done it.
Oh, no, we haven't. We skipped over.
Thank you very much and welcome back, everybody. If we go back to our agenda, we've had a very full morning, necessarily so. So we could be concise in the remaining papers. I'd really appreciate that. So the next one is 4.5, property asset strategic intent. Over to you, Lee.
Yeah, thank you, Chair. I will be brief because we have taken this through ESTOD and we did discuss it in committee previously. But what I'm presenting today is not something we've had previously as a health board. So it's a strategic plan which is presented today, which looks to set out our strategy for our property assets as a health board, provides a comprehensive baseline of our estate portfolio, both freehold and leasehold, and sets out our broad strategic intent as a health board in relation to these properties. It's a significant piece of work that's been developed with service leads and others, and seeks over time to improve the standard of accommodation, rationalise our estate, reduce our backlogs and reduce costs, and essentially provide a strategic framework for how we're looking to develop our property assets, and that can bring some benefits not just to ourselves but also to our local communities as well. So I wasn't going to say any more than that, but I'm happy to take any questions on it.
Many thanks, Lee. Are there any questions on this important piece of work? Good to have the clarity. No, thank you. Is the board happy to accept the recommendation? Thanks for this piece of work because it's important going forward. The next item on the agenda is we're going through annual reports. So it's the West Wales Carers Development Group annual report. Lisa.
Thank you very much. And again, I won't say too much about this. This report has been to 3 committees within the organisation already, so it has had quite a lot of conversation. It's just really great to see all the positive work that we're doing within the organisation to support our carers, and I thank the team for working so hard to help people, but happy to take any questions.
Thanks, Lisa. I think this began with the Anna Baird presentation, didn't it, when I first started, and what a journey. It's wonderful. Any questions? Just a huge thank you to the team and thank you to you. And particularly, with our demographic profile, I think we'll have more and more carers within our organisation. So many thanks.
Thank you.
Next item on the agenda is the report of the Sustainable Resources Committee. Winston?
I think I'll be quite brief on this one. I think the report's quite self-explanatory, but just want to bring to the board's attention a few things that we came across at the last meeting. And I think to a large extent we have covered some of this today. But we did have positive assurance at the last meeting on the decarbonisation presentation. As the board is aware, we did receive an award for that, and it was great to receive the enthusiasm of the individuals involved in that. We did discuss the in-year financial position remains a significant challenge, in particular nurse agency and progress and savings delivery. We've already covered that today at today's meeting in quite some detail. And also that meant that we had insufficient assurance at this stage regarding the annual plan. We did review and note the progress funds team and the organisation are doing on targeted intervention, and Arcus did a really interesting review about the opportunities for developing business partnering in terms of the finance directorate, and we were pleased to receive that. We noted that we need to do some more work as an organisation in reviewing operational risks of a financial nature. And I just think that reflects the busyness of the organisation at this stage. And similarly, we raised the risk around the risk of the health board not being able to meet its statutory requirement for breaking even. And I think those are the things that I just wish to bring to the board's attention. Thank you, Chair.
Thank you, Winston. As you say, we've discussed much of that today as well. Any questions at all? And is the board happy to approve the revised Sustainable Resources Committee terms of reference? Thank you. We go on to the next item on the agenda, and I think, Chantelle, you're going to take 7.2 and 7.3, the reports of ESTOC and the People and Culture Committee.
Yes, thank you, Chair. I chaired the Strategic Development and Operational Delivery Committee. Everything that is on the paper are things that we've already discussed today in quite a lot of details. So I'm not going to pick up on any of those other than to say that the scrutiny given at
for all of those items at the committee was obviously aired and discussed at length.
Many thanks. And you wish us to approve the terms of reference
Yes.
as well?
Yes, please.
Thank you. So the board happy to approve the terms of reference, and thank you for stepping in as chair.
Thank you.
The next item is yours, Chantel.
Yes, and in relation to the People Organizational Development and Culture Committee, again, everything that's on the paper are things that has been discussed at length within the committee. And the staff story is an item that it's a standing item, and it's great for us to be able to hear what's happening at ground level and all of the activities that are being undertaken by Lisa's team as part and parcel of the work plan. So again, I think we need to approve the terms of reference and everything else. I'm happy to take any questions.
Thank you. Any questions? Happy to approve the terms of reference. Many thanks. Thank you, Chantel. So the next item is the report of health and safety, Judith.
Yes, thank you. The report's there for people to see and ask any questions, although again, there's certainly one area which we've covered in detail. If I can draw your attention to the areas of risk, we did have raised concerns about the training facilities across the health board, and that is something which will be discussed through the people committee. Also, just concern about the security situation. We have approved the security policy, but we were concerned to hear that there was an issue with connectivity around the new CCT cameras which have been introduced, which the lead for estates, the lead for health and safety, Mandy, was going to take forward with our IT team. So happy to take questions, and also asking for the revised terms of reference to be approved, and the major incident plan, which is there as 7.4.1.
Thank you. Mandy, do you wish to comment on the CCTV provision?
If I may, Chair, it's just to say that a bid was submitted at the end of last year, opportunistically around the discretionary capital. The provision, the goods were purchased, as it were, and there was an expectation that the actual connectivity of that would be progressed at the same time. But because there were some delays in actually being able to get the cameras in situ, that's meant that there's been a delay in the connectivity. Hugh, who's overseeing from the digital perspective, and also the financial elements of it, we've had the further discussion, and we're looking at ways in which we can expedite the actual connectivity of the new cameras. I think it's fair to say, and I must advise, that the cameras are there as much as a deterrent. And we do still have cameras that are in situ and working. So it's being able to move to the upgraded system that is the issue. But we are progressing that.
Thank you. Do we have any dates?
We'd have to come back and confirm, because I'm waiting for Anthony to come back to confirm what progress has been made.
We'll put that in the action log. Thank you. In relation to the major incident plan, does it include responding to a pandemic?
Yeah. Sorry, excuse me. Yes, it does, but it's recognised that will need to be reviewed depending on the outcome of different stages of the COVID-19 inquiry.
Okay.
That was a question asked in the committee.
Thank you. But we've used our own learning, have we?
Yes.
Thank you. Any other questions?
If I may, Chair, it's not a question, it's just to point out that in addition to that, the conversation that we had this morning about the incident in Withybush, we've also are using that through a control group arrangement to make sure that any action cards associated with incident management on any of our sites is also built in and updated. And Sam Hessel, who leads on that, has actually provided assurance that that has already been undertaken where appropriate.
Thank you. That's very assuring. Is everybody happy to approve the terms of reference of this committee and the major incident plan? Many thanks. Thank you, Judith. Next item on the agenda are the committee update reports. Does anybody have anything that they wish to raise on any of those update reports? No.
Just need to ratify the terms of reference, Chair, for the relevant committees and advisory forums, Chair.
Okay, we happy to do that? Thank you. And then the joint committees and collaboratives, 8.1, Steve.
It's unfortunate. I'm happy to take any questions, Chair.
Thank you. Any questions on this? No. Board happy to accept the recommendation. Thank you. And then we go through the annual reports. And I think, have I missed anything?
Yep.
What have I missed? The cochlear and bone conduction hearing implant engagement and next steps. Alwena, your name is next to that.
I think my name's next to it, yes, and but it's actually the national engagement, and just for information, in a sense.
Okay.
I don't know if Lee wants to add anything to the question.
Yeah, it just presents the findings from the target engagement process and then sets out the next steps agreed joint committee, which is to identify the designated provider and then follow up a formal consultation process. Just for the board to be aware of that.
Okay, thank you. So it's noted by the board. Many thanks. And then statutory partnerships update, Jill.
Happy to take any questions, Chair.
Thank you. Any questions on this? No. Thank you. The board notes the update, and thank you very much. Then the committee annual reports, which they're all, it's amazing how much work is actually done when you look back retrospectively. So I want to just take the opportunity to personally thank the chairs of all the committees for the hard work throughout the year in these difficult circumstances, and for the wisdom of your advice and your challenge and your contribution. So thank you. So I'll go through them one by one, of any people to raise any issues. And Joe, tell me if we need to approve each one. I think we do. First one is Audit and Risk Committee. Rodri?
Right, I'll just go. Yeah, I haven't got kind of much to say. Kind of it's 29 pages, and I really am thankful to Joe and the team, Claire and Charlotte, for the work. And yeah, you can see kind of we have scrutinised committee support to the board by seeking providing assurance and controls are in place and are working. There has been 36, I think, different head of internal audit. There's been 36 audit reviews, and if you look at 7.2, it does say the board can take reasonable assurance that arrangements to secure governance, risk management and internal control within those areas in the review are suitably designed and applied effectively. Therefore, that is kind of, it's important. And going very fast to the end, which is kind of, because I know we're short of time, but if you look at the conclusions, it's acknowledged that the committee is well established. Committee will continue to request the attendance of the CEO, and thank you for your attendance so far. And as at 17.8, it's the opinion of the committee that the accountability report incorporating the governance statement, which was received at the committee meeting held on the 11th of May, is consistent with the view of the committee on the health board system of internal control. Informing this opinion, the following factors have been considered. Therefore, the system of risk management is adequate in identifying risks and allowing the board to understand the appropriate management of those risks. And the reliability and integrity of its sources, assurance encompassing the work of the both internal audit and Audit Wales, together with assurances forthcoming for the committee of the board, and the committee is reviewing the system in assurance whilst acknowledging the potential for improvement. Please, the health board has the necessary controls in place during the reporting period. Therefore, the board is therefore asked to endorse the contents of this report as a summary of the work and findings of the Audit and Risk Assurance Committee for the financial year 22-23.
Many thanks.
That's fast, 29 pages. Thank you so much.
Gold star. No, thank you. And it's really assuring and reassuring to hear the outcome of that work for us as a board collectively. So the board happy to endorse the annual report. Thank you, diolch. Charitable Funds Committee.
Diolch, Chair. Diolch, Cadeirydd. Well, we've got 19 pages, Rodri, so we're not kind of reaching the heights of Arac. However, members will see that this just reflects the breadth and the hard work of all the staff, but also our communities in actually fundraising for the charity. And it
what we as a committee really relish is hearing from our staff about the differences that fundraising can make to our patients and our staff and communities. So really, all I'm asking really the board is to endorse the Charitable Funds Committee annual report for 22-23 and onwards and upwards really. I think it's just wonderful. And next year's annual report, hopefully we'll have more information about the bronchitis chemo unit.
Marvellous. Thanks ever so
Thank you.
much, Delith. And as you say, to everyone for all this hard work, it's great to see it growing and growing. The board's happy to endorse the annual report of the Charitable Funds Committee. Thank you very much. Health and Safety Committee.
Yes, thank you, Chair. I won't go through anything particularly on the paper. It's there and gives the board the range of issues which we've addressed during the year that we've been meeting, as well as details of the number of meetings. And I do have to sort of commend the team for their attendance at these committees. We always have a very good attendance from the relevant officers. So I'm happy to take any questions, and the board is asked to endorse the committee's report.
Thank you very much, Judith. Questions? Board happy to endorse the report, and thank you for all the hard work, Judith. And then again with you, Judith, Mental Health Legislation Committee.
Yes, thank you. Again, the detail is there in the report. Obviously, this is a very specific committee, purely looking at giving assurance to the board that we are implementing the relevant mental health legislation. So that can be, I can give that assurance through this report, and happy to take any questions.
Thank you, Judith. Any questions? Board happy to endorse the report? Yes, thank you very much. And then the People, Organisation, Development and Culture Committee.
Yes, Chair. And again, the report is self-evident and it contains a lot of details. I just wanted to make a few observations that the committee was newly established 18 months ago. So to just take note of the amount of work that Lisa and her team has undertaken, and the reports that we get at the committee are very informative and gives us a really good flavour of what's going on at operational level.
Many thanks.
And the committee, the board is asked to endorse the report.
Thank you.
Happy to take any questions.
Any questions? Board happy to endorse. Thank you very much. And next is Quality, Safety and Experience Committee.
Thanks, Chair. Yes, nothing to add to the report. It is simply a collation of matters previously reported to the board over the last year. Just to recognise the team effort that it is to manage and operate this committee, and particularly thanks to Jo and her team for keeping us on the straight and narrow.
You missed that. You just had to thank
Sorry,
you for keeping on the stage. Trying to keep me on the straight and narrow at the moment.
It's happening as I speak.
Absolutely. living in motion. Okay, so thank you. Is there any questions? Board's happy to endorse the report. Many thanks, Diolch. Next is the Strategic Development and Operational Delivery Committee. That's you, Maynard.
Yeah, the report speaks for itself. A wide and varied agenda of S.C. We've covered an awful lot of ground this year. And I just like to pay tribute to my colleagues, both the exec directors and IMs, for the scrutiny they've given to the work, and ask the board to endorse the report.
Many thanks. Board, any questions? Happy to endorse. Thank you. And the Sustainable Resources Committee.
Thank you, Chair. I think the report is quite self-evident. 29 pages, and we've covered. It's been a marathon, not a sprint. I think it just reflects. We've only actually had 6 meetings, but it feels like 60. But we've covered a lot of ground this year. I just want to convey thanks to Hugh and his team, and the other exec leads who support the committee, and the IMs as well, and more in particular to Sarah, Bevan, and Joe's team, who've kept us on the straight and windy road of this health board's financial challenges. Thank you.
Many thanks. Any questions? Board happy to endorse the report. Thank you. Then we get to our year-end assurance, and can I say a very warm welcome? Anthony. Thank you for coming.
Thank you, Chair.
Yeah, just going to go through the agenda, and then Joe's going to tell me when you come in, if that's okay. Thank you. So the annual assessment of board effectiveness is 11.1.
Do you want me to start, Steve?
Could you? Yes, thank you,
Yeah,
Chair.
thank you, Chair. So I'm not going to go through the detail of this. So just to give assurance to the public, we did have a really robust session at our seminar on the 20th of April 2023, where the board agreed in terms of this year's level. It was level 4. We then further took through our relevant assurance process, and we discussed this in detail again at the 11th of May 2023, with the ARA committee recommending approval to the board of this and to take assurance from this year's assessment, Chair. So members have seen this several times.
Thank you. Based on that, the board happy to accept the recommendation, as we have discussed it many times. Thank you. And thank you, Joe. And the next is the Head of Internal Audit Opinion and Annual Report.
Yeah, thank you, Chair. That's just for noting, because I'm clearly not the Head of Internal Audit, but it's just important that we have that in the public domain, that again this year we received a reasonable assurance report from our auditors at the end of the year, which was pleasing to note. Those areas where we did receive limited assurance within year, we've included within the report to follow up either last year or this year to make sure that we're taking forward those recommendations, particularly in those limited areas. And just on behalf of the board, to thank our internal audit colleagues for the work they've done this year and supported us with, Chair.
Many thanks. And it's really, again, you know, we're going through this quite quickly because it's the end of a board meeting. Everything has been scrutinised and debated, and we have a reasoned assurance both from the external and the internal auditors, which I think is really reassuring. So thank you, everybody. And the next, we're going straight to 11.4, which is the annual report and final accounts for 22-23. So that is over to...
If I start and then hand to Hugh, if that's okay, Chair.
Great.
And obviously pass to Steve for the overall accountability, Chair. So yesterday in Audit Committee, we reviewed the performance report and the accountability report in detail. This was the second time of reviewing because we'd also already seen those in their draft format. We do need to, in terms of the accountability report, call out 3 areas of change which have we've moved since you've received your draft papers. So on page 192, there was a change to reflect that, to apologise to Maynard again. We admitted that Maynard Davis had attended 2 out of 2 remuneration in terms of service committee meetings, Chair. On page 76, we'd omitted the page numbers. On page 5 of the annual accounts, there was some hashes noted within the accounts that are presented, and the figures that should be in those columns are, I'm sorry, Hugh, if I get these wrong, I've written them down. So 1,154,992 in the first column and 1,152,733. We did go through those in detail yesterday at Audit Committee, Chair. So subject to that, I recommend the approval from Audit Committee, recommended approval today for ratification by the board of the first 2 elements, the performance report and the accountability report. Obviously, the accountability report is the Chief Exec's report, so I'll just hand over to Steve if there's anything further to add. Thank you.
I think Joe's covered it in a great way. I would just like to firstly record my thanks to all the teams who contribute to this at a busy time of year for us all, as we know, and also just recognise the work of Jo and her team in being the glue that holds that together. She doesn't just keep committees on the straight and narrow, she keeps pretty much the entire organisation on the straight and narrow. So I am very grateful for her inputs that, and I'm happy to seek approval for this report.
Thank you. And if I just bring Hugh in.
Yeah, great, thank you. Yes, as Director Corporate Governance alluded to, the accounts have been subject to 2 rounds of review by the Audit Committee, and obviously subject to the external audit from colleagues from Audit Wales. Just to rehearse the key position against our revenue resource limit, the year-end position is unchanged at 59,044 in terms of the position, and that was supported by a cash support from Welsh Government of 52.3 million in excess of our allocation. Our capital resource limit underspent by 69,000 as well, worth noting, and our PSPP position, so paying our bills on time or within 30 days of receipt of goods or invoices, we exceeded that target, achieving 95.5% against the 95% target. There were some changes to the accounts from the first version to the final version, subject to that audit process that we followed, and they are included on page 9 of the presentation that's appended. I guess there are a couple of things, and I'm conscious that Anthony will come in shortly, but wanted to recognise that there is, our accounts are qualified from a regularity opinion. We have spent more than the Minister could approve, and that is worth noting from the board's perspective, because clearly that's an unacceptable position for us to find ourselves in. But pleased to say that on a true and fair basis, then with the amendments that have been made, there is no issue to report, and nothing changed that affected the bottom line. It has been a longer audit process than expected this year, largely because of the introduction of IFRS 16, which Chair of Audit Committee took us through earlier, and the new auditing standards, which are much more risk-based and risk-focused, and we are seeing the benefit of that in the ISO 260 report in terms of some of the recommendations coming from that. I'd also like to echo that thanks to Director of Corporate Governance for keeping me on the straight and narrow, and that is a challenge. And thank you to her team for the support in pulling together the year-end process. It is a collaborative effort, and I'm grateful to that. Grateful to my own team for their work. It's been a challenging process to undertake, given the position across the NHS, and of course colleagues from internal audit and external audit, and the openness and benefit of the openness of our relationship, I think, shows itself in the governance arrangements we have in place.
Thank you, Hugh.
Chair, thank you.
And thank you, Steve, and thank you, Joe. On that basis, is the board happy?
No,
Sorry,
we'll
go to Anthony first.
And then to Rodri, because we just need from the chair of our Iraqi.
That's great. And I just wondered if anyone with mobile phones could take them away from their microphone because it's interfering. I did notice which hands moved, by the way, but I won't say who it was. Anthony, over to you. Thank you.
Thank you very much, Chair. And I was just going to, I'll keep this short this week, because I'm very conscious that the accounts and our audit report had a good review yesterday at the Audit and Risk Committee. But I should start off by saying, and again, a big thanks to Hugh and his team, Joe and his team, because it was a bit different this year. We were late starting, we were late finishing. It wasn't ideal for yourselves. Number of reasons for that, and we look to get it back on track ASAP. But thanks for bearing with us, and the collaborative approach really helped. So big thanks. Hugh's already mentioned in terms of the two opinions that we give, the true and fair opinion. Absolutely no problem on that front. The accounts are materially accurate. It's that regularity opinion which will be qualified for the reasons Hugh set out. Not quite just overspending the resource limit, but that's all accounted for then in the report. And again, in Appendix 2, we explain that in a little bit more detail for the reader of the accounts to understand the legislative background and the rationale for that qualification. There were a number of corrected misstatements that are included in Appendix 3. And again, the one thing that really struck me was none of the adjustments, some of them are quite large in volume, but none of them impacted on the bottom line. Okay, so ultimately just classification misstatements which have been all adjusted. So there's nothing in terms of our audit that hasn't been adjusted for in this final set of accounts. So that's good news. We raised a couple of issues, which I'm glad Hugh and his team have taken on board, a couple of issues that we've raised previously, and we look to follow up on those recommendations going forward. And they're covered in Appendix 4. The only other appendix I would draw your attention to, board, is the letter of representation that we get from yourselves, just to give us that overall combined assurance that everything is as it should be then, in terms of, you've disclosed what you should have to us in terms of compiling those accounts. So fairly, again, Chair, very standard, and there's no additional commentary within that letter of rep I would draw your attention to as a result of this year's audit. So just a big thanks for me and the team from Audit Wales.
Many thanks. Really reassuring. Okay, Rodri.
Yeah, good, thank you. Well, I've already thanked Joe. Hugh, thank you and the team, but also Anthony, it's nice to see you in person. We see you on screen every time, but thank you and Audit Wales for the kind of your contributions every time, and also to internal audit, if you could give our thanks to James and the team as well. Yeah, for assurance to the board, I can confirm that all elements of the annual report and accounts, that is the performance report, the accountability report and the accounts, have been reviewed in detail by ARAC in the draft format in early May and the final draft stage yesterday. I'm content that all required changes requested by Audit Wales and Welsh Government have been made and a robust audit trail retained. Following presentation to ARAC on the individual elements as described above and reviewing the ISA 260 with Audit Wales, I can confirm as Chair of ARAC that the committee approved the annual report and accounts and recommends these for onward ratification by the board.
Many thanks. Yeah, thank you very much. Does anybody have any questions at all?
Chair, there were two matters yesterday raised in ARAC in terms of the timescales for both the recommendations. First being the annual leave accrual and secondly the issue around CHC. It was mentioned we may pick that up on board today, or if you're happy, we can just put that on the tracker and follow it through, whichever way you're happy with, Chair.
Lisa?
If you just allow me to comment on the annual leave,
Yes,
the People OD Culture Committee next month. In the performance report now, we do have annual leave, so it is collected for all staff. It is now on ESR, so I can confirm that we have made that action.
Okay.
And we'll be able to regularly report it through the committee.
That's great. Many thanks. And the CHC?
Yes, Chair, we're picking up a piece of work on that in September. There are a couple of options that we're pursuing to make sure that the closing, the issue is that the system closes off about 6 weeks before the end of the year in order to validate the contracts that are outstanding. We've got a couple of options to pursue to reduce the length of time that the system is closed for. So we're working through those in September.
Okay, so we would put them on the tracker.
Yeah.
They would then be scrutinised in ARAC.
If they missed their deadline,
Yeah,
Chair,
that's
which
wonderful.
I've
Thank
dealt
you. So on that basis, is everybody happy to ratify the accounts as specified? Thank you, and well done, everybody. And thank you very much, Anthony. And thanks for coming. I know it's very, very kind of you. Thank you. So the next item on the agenda is the board work plan, which is for information. So we've seen that. And then the date. Well, actually, we have a number of meetings coming up. So the date and time of the next public meeting is the 14th of September, or do we have one
it is the
before then?
We've got an in-committee board chair on the 10th of August.
Yeah.
And then the next public board will be the 14th, but with the caveat what the Director of Planning raised earlier about the timescale. So we'll can pick that up, Chair.
Okay.
And it was a one-item agenda.
Okay, thank you. Then we have one on the 28th of September. And I think it's wonderful in my last few months that you're getting as many board meetings as possible. For my sins, I expect. Thank you, everybody. Steve, Steve would like to raise something.
It was actually just because I completely forgot to do it at the beginning, and it's a lesson to me to always read my notes. And it's also a fact that actually we're probably used to seeing her face around the place, but I should have, in my chief executive report, formally welcomed Ardiana Genie to the board, the first public board meeting as our new Director of Public Health. We're really glad to have you on board.
Huge welcome.
Thank you, Steve.
I think it is because we've seen you've attended the board seminar and you're part of the family now. So huge welcome.
Thank you. That's what I expected. I thought I'd seen there before, but no, thank you, and delighted to be here. Thanks for welcoming me.
Thank you. So that brings the formal board meeting to an end. And so if people who aren't part of the next part could leave the room, and we'll go into in committee for a short agenda there. Thank you. Could you just say definitely. I love this one.